we welcome you all to this session. Along with the complications in trauma, we are also going to talk about, the panelists are going to give some tips about exam preparation, how to do a presentation in a conference, how to select a journal topic for a journal discussion, how to select a topic for your thesis, and so on. So with these brief words, may I invite Dr. Senthil to introduce the panelists.
A very good morning to one and all. Thank you so much for investing your time with us on a Sunday morning. So my name is Senthil Murthy and I take this opportunity to introduce our speakers for the day. Today we have an amazing program for the next generation maxillofacial surgeons on the topic Nurture the Future, where we'll be talking about the big trends we need to keep our eyes on that could make us all better surgeons than before. And it gives me immense pleasure to introduce a moderator for today's event, Professor Ramakrishna Shenoy. Dr. Ramakrishna Shenoy, can I continue, sir? Is it audible?
Yeah.
Dr. Ramakrishna Shenoy graduated and completed his master's from Government Dental College, Nagpur, and he is currently the Vice Dean and Head of the Department at VSPM Dental College, Nagpur. He has a vast teaching experience of over 26 years and is postgraduate and a PhD guide. Professor Shenoy has more than 60 publications and written various chapters in books to his credit. He is currently an executive member of National State AOMSI as well as the president of the study group CIAOMS. Thank you, sir, for accepting our invitation to be the moderator for today's discussion. We are all looking forward. Now,
Thank you so much.
Thank you, sir. Now, let me take the pleasure to introduce our expert panelist. Our first panelist, Dr. Bhagwan Das Rai, is from Udaipur. He completed his master's from Bapuji Dental College and Hospital, Davangere. He started his teaching career at PMNM Dental College, Bagalkot, for 5 years. Since 2003, working at Pacific Dental College at various capacities, and is presently an in-charge president of Pahir University since 2018 October. He is an active member of IDA and served by holding various prestigious positions of the association, including being the president of the IDA Rajasthan State Branch. He has been a PG guide with vast 24 years of teaching experience and till date guided more than 35 postgraduates. He is also a PhD guide since 2010 and 7 scholars have pursued PhD under his guidance. He has various publications in national and international journals to his credit. He has delivered various guest lectures at various conferences and workshops. He held the position of past Honorable General Secretary of the Association of Maxillofacial Surgeons of Rajasthan chapter from 2011 to 2015. He is a past member of Board of Studies at Ramaya University of Applied Sciences, Bangalore, present member of Board of Studies Sumandeep Vidyapeeth, Baroda, present member of UG Board of Studies JSS University, Mysore, and current member of Curriculum Reforms of Maxillofacial Surgery. Thank you, Professor Bhagwan Das, sir, for accepting our invitation.
Good morning, everyone. Thank you, Senthil.
Thank you, sir. Our next panelist, Dr. Manjunath Rai, needs no introduction. Dr. Manjunath Rai is a renowned maxillofacial surgeon from Mangalore, India. He completed his master's in maxillofacial surgery from A.B. Shetty Memorial Institute of Dental Sciences, Mangalore, in the year 1998. Later, he became the member of Royal College of Surgeons of Edinburgh, UK, since 2002. The subjects of his interest were on head and neck oncology, orthodontic surgery, maxillofacial trauma, and implantology. Apart from maxillofacial surgery, he pursued his LLB from KVG Law College, Sulia, and postgraduate diploma in medical law and ethics from the prestigious National Law University, Bangalore. He is the fellow of the Indian Board of Maxillofacial Surgery, presently working as the senior professor, head of the department maxillofacial surgery, AJ Institute of Dental Sciences, Mangalore. He is an astute practitioner running a successful practice in Rai Dental Specialty Clinic in Mangalore. Dr. Rai is having the rare distinction of being the youngest person to hold the post of Honorary General Secretary of the Association of Maxillofacial Surgeons of India for 2 consecutive terms. He has more than 28 national and international scientific publications to his credit. A good orator, and he has been an invited guest lecturer at various state and national conferences both in the subject of maxillofacial surgery and in the field of law. The JC International recognized his achievements and awarded him as the outstanding young person in the field of medicine for the year 2010. He was also the former Senate member of the Rajiv Gandhi University of Health Sciences, Bangalore. Dr. Rai presently is the president of Karnataka State Chapter of AOMSI and also the president-elect of the National AOMSI Head Office. He is married to Mrs. Aparna Rai and blessed with two kids, Ms. Bhumi and Master Gagan. Thank you, sir, for accepting our invitation.
Thank you, Senthil, and good morning to all.
Our next panelist, Dr. Deepthi Simon, is from Thiruvananthapuram. She graduated and completed her master's from the University of Kerala. She completed her postdoctoral fellowship from Sri Chittare Tirunal Institute of Medical Sciences and Technology in the year 2006. She completed her diploma at National Board in the year 2007. A PhD scholar under the University of Kerala, now working as an associate professor in oral and maxillofacial surgery, Government Dental College, Thiruvananthapuram. Thank you, ma'am, for accepting our invitation.
Thank you, Dr. Senthil, and good morning, everyone.
Our next panelist is our very own ever enthusiastic Professor Dr. Ram Kumar. Professor Ram Kumar completed his master's in maxillofacial surgery in the year 1998 from Raja Muthiah Dental College and Hospital, Chidambaram. He completed his diploma in National Board successfully in the year 2001. He has his diploma in diode lasers from the Indian Academy of Laser Dentistry and is an associate fellow in the American Academy of Implant Dentistry since 2017. Having trained more than 60 postgraduates as internal and external examiner, which includes myself, presented and published various articles in national and international journals to his credit. He has organized a national conference and multiple workshops in CMAs. With over 18 years as an excellent academician and over 20 years into private practice, he is currently the director of Locus Dental Care in Chennai and a consultant maxillofacial surgeon at the Parvati reconstructive surgery, cosmetic jaw surgery, obstructive sleep apnea, facial deformity correction, cleft lip and palate, distraction osteogenesis, and dental implants. It was indeed a great honor for me to introduce you today, sir.
Thank you, man.
Our next
Good morning, all.
Until we have lost you. Okay, the next panelist, Dr. Kannan, did his BDS and MDS from Ragas Dental College. And right now he is working as a professor in oral maxillofacial surgery at Ramakrishna Dental College, Coimbatore. He has been very active in his private practice in Coimbatore and specializes in trauma, orthodontic surgery, and oral cancer. He is right now the editor of our newsletter of the Association of Oral Maxillofacial Surgeons of India, Tamil Nadu and Puducherry branch. Welcome, Dr. Kannan, to the program.
Yes, sir. Thank you, sir. Good morning, all.
Thank you, Dr. Senthil.
Thank you, sir. Sorry, I got interrupted with my connection, I guess.
No worries. Yeah. Over to Dr. Ramakrishna Chennai to take over the session.
Yeah. Thank you, Dr. Jimson, and the Association of Oral and Maxillofacial Surgeons of Surgeons of India, Tamil Nadu and Puducherry branch. It's indeed a great privilege for me to be the moderator of this very erudite panel comprising of two Rais. So we're going to have a lot of Rais over there. Forgive me for saying this. And and with Ram Kumar, Deepthi, Kannan, and this session is just going to rock. What we are going to talk is a continuation of the complications of trauma, which we have seen in the past two episodes. And I must really congratulate the TN and Puducherry branch of AMSI for being very persistent and perseverant in having their webinars every Sunday. Hats off to you guys. You have a big fan following across the country and the globe. So what we are going to talk about in the first part is complications of trauma. And of course, in the second part, we've got the panelists speaking on individual topics such as, preparing for exam by Dr. Bhagwan Das. Dr. Manjunath is going to speak on PG activities such as Journal Club. Dr. Deepti is going to, throw some light on thesis writing. Dr. Ramkumar is going to tell us how the future goes for the maxillofacial surgeon post MDS, and Kannan how to do a proper case presentation. So going ahead with the presentation, the first complication that we are going to talk about is the malunion, right? So malunion is something that we get to see, not very uncommon, but it does happen. And it happens because, we have some problems in getting the proper fixation. The mandible is the usual victim of this particular thing. And of course, sometimes the zygoma and indeed even the maxilla is a part of it. So I will just put, the theory behind it, that is segments which are united in unusual position. Sorry, this is malunion. Yeah, segments that are united in unusual position. The function is compromised. At the end of the day, when there's a patient of a fracture, right, and if the fracture gets gets a malunion, then obviously the patient is not going to chew or masticate, and this leads to a lot of problems. So, and of course, once the function is compromised, many times even the form is compromised in the way of aesthetics. So, what are the challenges that we have? So the challenges are, as I said earlier, it's malocclusion, the vertical height changes, the secondary deformity, jaw movements, and pain and discomfort. Bhagwan, would you like to speak something about this?
See, regarding malunion, when we are talking, am I audible?
Yes, yes.
Yes.
Yeah. One thing, clarification I want to start with, because in the later part of the discussion, probably we'll be landing into this. Condylar fracture, when we do no conservative management, we need to accept one fact is we expect and accept malunion there. And second thing is condylar malunion is not synonym with malocclusion. This concept, I think we have to take it into consideration. And further, I think we can go ahead with the case as the discussion comes.
Yes.
One, this is an important fact. Every postgraduate should know that non-surgical management of condylar fracture, we expect and accept, because there is no complete union which is taking place. It's not like other part of the mandible where there's a close reduction and complete approximation is there. And not necessarily that malunion leads to malocclusion.
Ramkumar, malocclusion can also result because of, a maxillary fracture, a LIFO fracture not getting united, or getting united in a different form. So your take on this?
Yeah, whenever you have a mid-face fracture along with a mandibular fracture or a panfacial fracture, yes, definitely it's a problem towards the regaining the occlusion. When it is complicated with a split in the maxilla, it is going to worsen. As a beginner, maybe sometimes we don't really completely diagnose the midline or the split in the maxilla, and we are in a hurry to fix the arch bars and go ahead and look at the occlusion and then fix the plates. But at the end of the day, you might have a split maxilla where it can complicate and things can go on like that. If you can show a couple of cases in that,
I will. And Manju, just one last thing, since there are a lot of orthognathic cases which go around in your center. What can you talk about the secondary deformity before I move to the case?
You're talking about malunion eruption, right?
Yeah, malunion, the secondary deformity that results because of this.
Yeah, see, the 2-3 things I just want to add on from what Ramkumar left is many times some of the cases are with a head injury, or patient is on, not suitable for a surgery, gets delayed, and sometimes, sometimes the malunion is because it's not reduced properly or it's been untreated.
Yeah.
All this will result in a big secondary deformity. and things becomes worse as the time prolongs. Now, when now suppose say when the dental segment is involved, there is a lot of supra-eruption can happen and occlusal changes can happen. So in such cases, doing a correction of a malunion will not simply refracturing alone will suffice. So you need to take into consideration whatever the occlusion, I mean whatever the occlusal compensation, whatever has happened. So you need to consider even that also. So
Yeah.
both, obviously, both functional and aesthetic. So
yeah, sorry to interrupt.
so sometimes in case you may have to do orthodontic surgery also to correct some of the malunions, say when it involves a mandible kind of a thing.
Would there be a period by which we can call it malunion? I don't think so, to my knowledge. I mean, malunion would be obvious once you release the intermaxillary fixation or you find a few days later. A radiological change as well as a period where you can call it as a non-union or a delayed union can happen, but malunion is visible instantly, right? Once you release the patient from an IMF and you realize that something's gone wrong. Am I correct in what I'm saying?
What I'm trying to tell you is, okay, go on, Ram.
Yeah.
Yeah, it's very obvious. If there is a malunion, it would have fused in the wrong position, and your anatomical reduction would not have happened. So we don't need any double confirmation. The functional and the aesthetic and the occlusal variations will straightforwardly tell that it is a malunion.
Okay. So now we come to the first case. This is a case where you can see, Bhagwan, can you throw some light on this particular case?
Yeah, radiographically, we have the orthopentomograph, which is seen with the hardware at upper border and lower border. One looks as a two-hole plate, and another looks like a three-hole plate. And looking at this, the other side condyle also seems to be out of the glenoid fossa on the left side. And it looks like there is a dearrangement of occlusion. It's a clear-cut treated case where there is malunion. Clinically also, we can see there is a step which is there between the lateral incisor and the canine there. And definitely there is functional disability to the patient apart from aesthetic also. So this particular case definitely has to be there is no way that we can manage non-surgically. It has to be managed surgically. This is the first point. Second is probably the refracturing, and probably we need to address the condyle also. But before that, getting into occlusion is a challenging job. Without removing the hardware and refracturing, that will not be possible.
Yes. Kannan,
Yes, sir.
Your thoughts on this?
So I would like to add upon few points, particularly regarding the operative points. So here the Champy's line of osteosynthesis is clearly missed out in this case. So we need to have two stable plates, but here we have only one two-hole plate and the other one is a three-hole plate where there are only one hole in one particular segment. So it is not going to be stable following all the three compressive, tensile and torsional forces. So the segment is going to get displaced. So had it been addressed for the condyle and also for the two plates following the Champy's EVO principles, the patient wouldn't have had this complication at all. And then again, the difficulty here is there is an overriding also.
Yeah.
Rather than the left segment has come down and there is an overriding. The right segment has gone lingual to the left segment. So refracturing, and then when we are uniting it, there may be some again difficulties in approximating the ends together, sir.
So Dipti, taking on from what Kannan said, if you refracture it, would you need to have a graft and a reconstruction plate? Dipti?
Mic is mute.
Okay.
Just unmute.
That would be a good option, sir.
Yeah.
That would depend on how the intraoperative scenario plays out. because if there is a gap after the refracturing, a graft should be placed.
Right.
Otherwise, again, we'll have the same problem of the mandible collapsing inside lingually
Okay.
post-operatively.
So this is what I was talking about. This is what you see. Would a reconstruction plate help?
A 2.5 reconstruction plate does help, sir, in some cases.
Yeah.
And
So-
again, I guess the fracture looks pretty oblique. So in
Yeah.
the first case, I guess a lag screw would have been a good option as well,
Right.
given the anatomy of the fracture because of the obliqueness.
Dr. Shenoy, can I
Yeah.
add something?
Yeah, please, please.
So
Yeah.
if we look at the primary scenario, it would have been a clear-cut oblique fracture of the symphysis or parasymphysis, whatever, and a dislocated unilateral condyle. So for the beginners, ideally it would be, if you want to avoid operating on the condyle, keep it aside, treat only the dentoalveolar component, use exactly 2 mini plates first to fix it in the line of osteosynthesis. That will suffice. Looking at the radiograph, it doesn't look like it has any big bone loss or anything. But if the malunion is for a longer period, if there is aberration on the ends, then we can think of other options. But even to refracture and do it, I think ideally 2 simple plates, a 4-hole or even a 6-hole plate in the bottom and a 4-hole on top will suffice, getting the good occlusion. This will be the primary advice for dentoral area. If the surgeon is capable enough, then he has to definitely attend to the dislocated condyle also, because it is totally out of the fossa. There is going to be extreme deviation and difficulty in chewing. So this will
Yeah.
be my suggestion.
And how do we address the condyle? In this case, I believe it's got dislocated a lot. There seems to be a dislocation.
Yeah, definitely. In today's world, if you can take a 3D CT, you can really appreciate the anterior-medial dislocation or a complete subluxation from the joint. And then we
Yeah.
can definitely plan at the level of the subcondylar cut or the fracture. And ideal would be a transported or a retromandibular. That's a
Yeah.
straightforward procedure these days in almost every center. And I'm sure all of our surgeons will be able to comfortably plate 2 plates in that area. Retromandibular is good enough.
Okay. So the take here is that if the malunion is quite extensive, I mean, and there's disfigurement in terms of, disturbance in terms of occlusion as well as that's function, as well as the form. If you look at the patient, I think the patient's face looks a little longer, So in such cases, it's always better to go in for a corrective surgery in the form of what our experts have said. Now coming to the second complication, now that is what some people have already started asking. The second complication that we are going to deal is non-union. Okay, so non-union is something which I also spoke earlier. So non-union happens because of the mobility of the fracture segments, which is not addressed to. So I'll begin with you, Kannan, right?
Yes, sir.
So
Yes, sir.
Yeah. So Kannan, as you can see that there are separated ends, fibrous union. Now, can you just throw some light on delayed union and non-union?
Yes, sir. So non-union is totally, the segments have not united together, sir, because of inadequate immobilization, sir. So delayed union, there will be more of fibrous union between the segments and getting delayed, and there is constant mobility between the segments, but united to the fibrous unions. And here, the problems will be when we try to address this, they may be united by a fibrous, when we will have to remove those fibrous tissue in between the 2 segments. And there may be a gap between the 2 segments. When you try to fix them, there will be a graft between the 2 segments and ebonite ends. So either we will, if the gap is too much, we'll have to go for a graft or cancerous graft with a mesh covering the between the 2 segments, occupying the space between the 2 segments. And it is always easier when it is detected earlier than getting it detected very late and operating it.
Yeah. So what happens in delayed union is that the callus is there. There are vascular channels which are there. And in non-union, there is absolutely nothing. You got hibernated ends, and obviously there's going to be a lot of mobility. So if we look at this, this particular case, which I'm going to show, this is a case of non-union. You can see it in the OPG as well as in the CT scan. Manjunath, can you throw some light, please, on this?
Yeah, now what you can see here is on the right side, condyles are absolutely not in the glenoid fossa. And yeah, now maybe it has been treated conservatively. That is what has been happened. So, and as Bhagwan Das Ray started this particular point in the beginning itself, now you're talking about when you do, when you don't open the condyle, and in many times, as you need either a expertise, or sometimes when the fracture is high, sometimes, and for the fear of complication, many times condyles are not addressed. So this can result in a non-union, and in condylar fracture, as a part of the conservative management, it is accepted.
Yeah. Bhagwan, one last
regarding this particular case, if there is a complete occlusion is not able to be achieved in spite of doing a conservative approach, we need to understand one: maxillomandibular fixation followed by functional therapy is one important thing. And for all the postgraduates, one important article has to be read by each and everybody is the treatment of mandibular condylar process fracture by biological consideration, Edward Ellis, 2005, JOMS, which clearly talks about neuromuscular adaptation, skeletal adaptation, and dental adaptation. This functional therapy is the very important aspect when we do a conservative management of condylar fractures. If it is a minor discrepancy, and we have to have a clear-cut idea when we should go for a surgical treatment in a condylar fracture malunion resulting in malocclusion.
Okay.
Okay.
Yeah. So this was the basic history. It was done with a conservative management. Should we be aggressive when we are talking about condylar fractures?
I think, Dr. Shana, if you want to, I think we should be more aggressive in managing the condylar fracture. The reason is like, compared to earlier, now more and more units are operating on condyles, and compared to the earlier, definitive indication, we have moved quite this one right now. Now those absolute indications have changed a lot. Now, so the more and more units are actually opening the condyle. The reason why I'm telling you, as when you open regularly, you are aware of the local anatomy, you are aware of the complication, and you yourself are prepared, as well as you have prepared your patient also with the proper consent. So you expect some sort of there is a possible complication, and then move away. I mean, move with it, so that more you do, you become more experienced, and you wouldn't mind opening the more of the condyles. So definitely nothing to this one. The best thing is to have a anatomic reduction. The advantage is huge with certain amount of risk. That's always there.
So
and I think, Bhagwan, just 1 minute.
Yeah, okay.
I just wanted to say to what Dr. Manjunath has said, with the advances in the geometry of the plate for the condylar plates, there's a big boon, because you can do with one plate with a variable geometry rather than having to put two plates or one plate, which you normally gets fractured. Yes, Bhagwan, please come in.
Yeah, when he told about that, we should have a clear-cut distinction that definitely the displaced and dislocated condyle 100% we have to address with open reduction and surgical management. Then we can have the other one, undisplaced or slight deviated condyles. You can still think of conservative management. But here, when displaced and dislocated condyle, we cannot, or we should not think of having a closed or a non-surgical management.
Yeah.
So,
Kanan, you wanted to say, yeah.
Yes, sir. So the same case, we have both the scenarios. The left side, we have a condyle which is within the glenoid fossa, where we can accept the even a malunion. So due to the functional adaptation, but on the right side, it is totally dislocated and displaced. So we may have to think about anatomical reduction in this case by surgically opening and fixing it, maybe probably with a delta plates, some better plates.
Yeah. Correct. Yeah. So thank you so much, panelists. And I'll just go ahead. Ramkumar, my next question is to you. This is a case, you can see the history. It's an unattended palatal split, mid-palatal split in a LIFO fracture. The patient has nasal regurgitation. So your thoughts on this?
Yeah, like if you remember Dr. Manjunath telling, most of the case of mid-phase associated with head injury are delayed in the ICU to be operated. So often these end up having that split maxilla for a longer time. And when we intervene, we tend to ignore it fully well. We try to adapt the arch bars and fix all the external plates, the Lefort level, the Lefort 2 levels. But if we don't keep this in mind, that is the transverse splaying of the maxilla in mind, and if you don't try to do a transosseous wire or try to hold it with your Hayton Williams forceps and tighten it and then fix the plates, we are going to have this problem post-operatively. Sometimes we can have a fistula if it is a healed one, where you will have constant regurgitation, or sometimes like this poorly healed bony segments of the maxilla. In both the cases, we need to aggressively take up immediately without delaying, because to have a malunion in maxilla is really, I mean, non-union in maxilla is really bad, because you will have the aberration through and throughout, and it is not easy to refresh and pack it well. Because if you regularly follow up the immediate post-operative period, we will come to know about the regurgitation one. Second, the maxilla on clenching will hinge. The patient will be complaining that the mid segment is still hinging or splaying. In that case, we can take up this case. So how do we manage? Two things for a beginner. We can think of making an impression and making a plate. Okay, we can simply conservatively have a palatal plate and tighten it so that you get both the left and the right segment close together. Or if you are taking up under theater, then again a transosseous wire and then retighten the Lefort level plates. So this is how you can manage. In the worst case scenario, where you have a slightly bigger fistula which was ignored, or the patient did not turn back on time, then we have to treat it like an a nasal or an oroantral fistula. Like a cleft palate, you can try to get the laterally positioned flap close to the midline and try to suture. Remember only one point as a beginner, it should minimum be a 2-layered closure. Try to clear the nasal layer closure, make sure it is watertight, and then go for the palatal. If that is done, even without a part of bone, it will still heal and patient should be all right. So this is how we can think of managing the entire scenario.
Yeah. What happens is that we are a part of the secondary survey. So rightly said by you and Manju that we come in later, and by the time this complication has already happened. So this is a problem that we need to deal with.
Yeah, I have one more point to tell. Yeah, can I add one more point?
Go ahead.
Yeah, especially in the panfacial fractures, when we try to have this submental intubation, sometimes after fixing everything, we will not open the mouth wide enough to really check the palate to see whether they are close enough. Sometimes we ignore. Sometimes it is too difficult because you are having that submental tube and you have the throat pack and mouth opening. You are scared because you have just fixed all the plates. So sometimes you will see and sometimes you will assume it will heal. But those are the cases which are going to give you problems. There'll be lateral splaying or a gap. I have personally had 2 cases where a fistula happened, and after 6 months we had to refreshen and then close them. So that point you have to keep in mind whenever it is a panfacial and whenever you're doing a submental at the end of the surgery.
Correct.
Thank you.
Yeah, Dipti, I'm coming to you. Next complication is going to be diplopia. Okay, so diplopia, as we all know, it's double vision. The types, that is binocular and monocular. How would you differentiate, Dipti?
So the patching test?
Yeah, the patching test. You're absolutely right. So any other tests that are, yeah.
So the first thing is what the postgraduates should know is checking the vision is most important. That is eye examination, the visual acuity, whether vision is present in both the eyes, because we end up in a lot of medical legal complications later on, sir, if it is not checked. And only then should we go in for checking the double vision. Uh, so that is most important, examination of the eye and the visual acuity.
Yes. So how would you get about doing it? What are the tests? I mean, what can we do as a resident in rather than waiting for the ophthalm people to come in?
So this can be done chair side itself, sir. The one eye can be
Yeah.
closed, the good eye can be closed, and the patient is asked to see whether they can see your finger at a 1 meter distance. The same thing can be done with the other eye, and you can judge whether there is vision, and
Right.
if the patient is having diplopia. Then we can have the eye movement tester, and all the 9 gazes of vision. One can move your finger at a 1 meter distance. The central gaze, the lateral, the superolateral, inferolateral, all those things can be done right on the right at the chair side. So
Okay.
in this case, when we do this particular test, we can see whether the movements are there. The patient will then say whether they have diplopia. We can assess it in which direction they're having the diplopia, and only then we need to advise the HES test. The HES charting can be advised later on.
Yeah, that's right. How would we differentiate between a mechanical obstruction due to trauma and a nerve palsy?
Sir, nerve palsy is something that uh, that is, it doesn't come isolated, sir. In the sense,
Yeah.
it's when you get a for example, if it's a lateral restriction, then well, it's for sure, in most cases it is definitely due to abducent nerve palsy. That's usually because of palsy. It
Right.
depends on the direction in which the eye is not able to move. On the other hand, sir, you can definitely see a mechanical obstruction due to trauma on a CT. Definitely, you can see that.
Yeah.
The maybe not the muscle per se, but at least the tissue surrounding the muscle, there will be some obstruction. That there will be some edema there, or a bone can be there that is entrapping the tissues around the muscle. Probably not the muscle per se, but the tissue surrounding it. Then, of course, we have the force duction test, sir, that should be done.
Yes.
That is probably the most conclusive test that we can do. And we have these beautiful signs on the CT scan. That is the teardrop sign. We can even appreciate that on a PNS view if taken properly. Uh, those are the things that can help us to diagnose mechanical entrapment.
We have a CT, which I'll be coming in the later
Yes,
case
sir.
discussion. We'll be having that CT scan where you can see
Yes.
all those signs which you're talking about. So
Yeah.
there's a question from the audience, is that how to assess for ocular moments if the patient is having periorbital edema causing a pseudooptosis. Anybody care to answer that? How would you assess the ocular moments with periorbital edema?
Sir, it is not wise
Would
to
we?
open the eyes,
Yeah,
sir. I mean,
with so much of edema, I don't think it's very
yes.
wise to. Yeah.
It is not wise because that can cause chemosis. That's what.
Yeah.
It's not wise. I think that should be done by an ophthalmologist rather than us, because in case there is some conjunctival damage, then again that complicates the situation. That can cause further problems. That is what I believe.
Right.
There is no point in forcing the eye open.
Okay.
Maybe we can wait for the edema to subside, sir.
Yes.
Can I add, sir?
True.
Yeah.
That's
Yeah.
very
Maybe
true.
we can wait for the edema. Maybe we can wait for the edema to subside for days with steroids, and then once the edema subsides, we can go in for checking the movements. Sir.
It would be unwise to intervene when there's a lot of periorbital edema.
Yes.
Not our cup of tea. So the timing of intervention is, early intervention. If there's no problems like what we have, So an early intervention would, you know, involve the release of the entrapped muscle or the periorbital contents, and then follow it up later. And if there's late, then what do we do?
Sir, can I put in a
Yeah,
word on this early entrapment, sir?
yeah, please go ahead.
Sir, I think the postgraduates should know that there is something called a white eye syndrome, sir.
Yeah,
A white eye syndrome is something that is usually seen in young children, where we have a trapdoor fracture of the orbital flow. And the child will not be able to raise the eye, but when he tries doing it, he ends up in vomiting and all kinds of issues like that, bradycardia and all that. So that is actually, it's supposed to be treated like an emergency. That is one
yeah,
area where we have to open right away, because there is some sort of vagal stimulation here when the child tries to do it.
that's the
So
oculocardiac
and
reflex.
yes, yes, sir. And it ends up in a compartment syndrome, even the muscle itself, because the amount of muscle entrapment that is seen in children, I mean, instead of the surrounding connective tissues getting entrapped, for children, the rectus muscles, actually, that gets entrapped. So if that can be released immediately, this whole problem can be solved. So you may get a question like, what is a white eye blowout, or what is a white eye syndrome? That is actually a compartment syndrome. It has to be addressed immediately. And
Yeah,
otherwise it may go into necrosis of the muscle per se.
yeah. Ramkumar, what material is your preference for orbital fluid reconstruction?
Yeah, straight away, anything with titanium is good enough, like a mesh. That is what
Yeah,
is routinely used and quite safe. We have been using it for long. There are a lot of literature supporting it as well. And depending upon the bulk, you can even add an autograft on over it, or you can fat fill and you can obliterate. That will be my
yeah.
answer.
We are talking about stereolithography and patient-specific implants. Would Manjunath want to throw some light on this?
Rakshana, yeah. Now, if you're going for a, I'm talking about the secondary orbital flow. I mean, correction. Are you? Is it?
Yeah, 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 yeah.
Okay. Now, because if you're going for a definitive secondary orbital correction, you need to be well prepared. Uh, in the sense, you need to be do the all the diagnosis right. So whether if it's if in case there is a volume loss because of either non-correct, I mean it's not been corrected properly, or if there is any ZMC along with the orbital flow fracture, that needs to be addressed properly. So definitely, stereolithographic model will actually tell you uh, how and once we have a stereolithographic model, we can even order a custom made this one also. What is that?
An
Custom made
implant.
implant for a floor, as well as so that the volume has been taken care.
Yeah,
And in case along with that, if there is any still there is a if there is a diplopia or any other ocular movement, so we also needs to have a MRI to know exactly what exactly is happening along with the movements of the whether there any muscle involvement and all that. So we need to, if you're going for a secondary corrections, get all the information and then go once and do whatever the best possible.
okay, this question is open to anyone. Post-surgery, if post-surgery there's a persistent diplopia, what would be the cause? Um,
Uh, maybe maybe sometimes even due to muscle spasm if it is intervened very later.
yeah,
Maybe we can add upon muscle exercises and eyeball movements, see if it gets improved over a period of time. And we can also check with a post-operative CT whether still some amount of entrapment is still there.
right.
And then we can move accordingly.
So there's one suggestion also. I mean, what about prism glasses used by ophthalmologists for persistent post-operative diplopia? I think we could use it. There's no harm in saying no to it. So these are the typical features of a blowout fracture. And the image which you see on the lower right-hand side corner, the encircled one, that is the sign that Dr. Deepti was talking about. right? So these
Yeah,
are
yes,
the,
sir. Exactly.
yeah. So Kannan, just a quick run of this, run through to this case, because we have got
Yes.
a lot of cases to be discussed more.
Yes, sir. Yes, sir. So here, his eye movements were checked in all the directions, all the 8 directions, and he has a difficulty in upward gaze on the left-hand side, sir. This is as suggested with the last picture, and it is correlating with the CT picture. There is an periorbital content herniation into the maxillary sinus, causing entrapment of the periorbital content, including the inferior rectus muscles. He had a diplopia also, and there was a force reduction test which confirmed it to be muscle entrapment rather than a nerve involvement. So he better if he is operated with a repositioning the periorbital content and separating it with the orbital mesh, titanium mesh will be good for this patient, followed by a physiotherapy like eye movement exercises.
Okay. Kannan, there's another question related to this. What is the efficacy of Medpor mesh as compared to conventional mesh? Medpor mesh for floor reconstruction.
Yes, Medpor mesh, I think we can use Medpor mesh, but not as efficient, in my opinion,
yes,
not as efficient as a
titanium mesh. Correct, you're right.
Yes, sir. Yes, sir.
Bhagwan?
Titanium is quite malleable and
Yeah.
it's very refined. Now it's come with very fine titanium meshes. I don't think with this Med4 thing we can manipulate anything if we need to contour it. That
Yes.
will be a problem. That will further lead to complications if it gets displaced posteriorly. Fixing of it is also another problem. Med4 implants.
Yeah.
Yes, sir.
Bhagwan,
Yeah.
can you just give us some tips on the adaptation of mesh for the floor?
See, probably what we try to follow is try to take a skull priorly. If when we don't have a stereolithographic model, so
Yeah.
try to adapt it prior to the surgery, almost 50% of it. Then at the time of surgery, we try to take a small template-like thing and try to modify that one. The ideal way would have been having a stereolithographic model and then contouring it so that during surgery we won't waste the time and the whole job is easier. That will be the best way of doing it, because PSI will be very expensive, patient-specific implants.
Yeah.
So having a custom-made one and adapting with a stereolithographic model will be very ideal one.
Okay. So now I think we'll wrap up this discussion on diplopia, because we've got many more complications that will be coming up. And if there are any questions that are from the audience, we'll put them at the end of the case discussion, the complication part, and then move on to the individual presentation. So the next complication that we are going to talk about is post-condylar surgery complications. But this is something, this is a fear that we have in our mind for approaching the condylar fractures, as Dr. Manjunath said. But then we are overcoming that fear and we are going in for more and more, addressing the condyle. However, this leads to certain complications. And the first complication and the most worrisome part that we are going to face is the post-condylar surgery is the facial palsy one. So this is a typical feature of this. How do we prevent it, Manjunath?
Okay, now, yeah, everybody wants to prevent it. The only thing is, we need to be, see, the thing is, need to be careful. Yeah, obviously, everybody wants to be careful again. Selection of the approach. That's first and foremost. Okay, so we have many approaches, preauricular, submandibular, and these are approaches. Depends upon the level of the condyle fracture. Okay. Now, other than that, how do we prevent it? Okay, as it's put up in the slide itself. Yeah, sound anatomy. You need to exactly know where exactly you need to stop. Okay, now where exactly the branches of the starting point of the patient now to start with. So you need to be very careful and do a skillful dissection and go layer by layer. Keep an eye on if you have a nerve stimulator, it's really good. It's going to help you, because and even if you the twitching of the muscles when you're using a cautery, in monopolar cautery, and a slightly low power, and would help you to know you're coming to the vicinity of the nerve. So be careful, do the dissection. Okay, now even after doing the dissection, the retraction also causes a lot of results in a transient facial palsy, might not be a permanent one. So careful is a keyword. Go layer by layer, take all the precautions, and then go smoothly and get into the. Uh, there are various ways of doing it. Some people go transparotid, some people go the through from down and retract the entire parotid, and then so there are many methods for condylar neck approach. So we need to have a sound anatomy, and then do a careful dissection, taking care of all, and preparing ourselves as well as prepare the patient itself. Okay, it's not that if you say that prepare the patient, take a consent for these are the possible complications. So, and tomorrow if the patient says that why you didn't inform me, you better inform, put it in a consent, written informed consent, and make sure the patient is aware of this particular thing.
Yeah. So, we can have a retraction injury, a simple thing like a neuropraxia. Am I right, Kannan?
Yes, sir. We can have a retraction in a simple neuropraxia, which may heal over time with steroids, very good against neural inflammation. So steroids and maybe methacobalamins. And the suturing, when we are trying to avoid silo seals and we are more focusing on layer closures, we may nerve within our suture lines, which can also cause palsy and to a direct severance of the nerve. So instead of getting dissected out, and neurontomesis also, sir.
Yeah.
So in
Sometimes
Yes,
what we have missed, which you have added over here, is the suturing injury. So this is something like you said, we might include the nerve in the bite, and then that can cause a lot of problems. Yeah. Okay. So the next complication that we are going to deal with is the siloseal, and not an uncommon thing that can happen. So one question that has come is, Bhagwan, that should we try to skeletonize the marginal mandibular branch in the Risdon approach, since we've talked about the facial nerve paralysis? So should we do it or we shouldn't do it?
I think we have never done it because when we know the incision properly and when we go with the anatomy, I think for a beginner, it might be ideally recommended. Not to prevent, because for them, if in the initial stage, if they have complications, that will deter them to further progress in maxillofacial surgery. I think yes, for a beginner, yes.
Ramkumar, your thoughts on siloseal?
Yeah, siloseal is one of the common complications if our suturing techniques and the principles are not followed well. This can almost happen in every case if we don't suture back the transparotid or the retromandibular approach properly. It means, as we understand the approach towards surgery, we have the skin, the subcutaneous tissue, and the platysma, and you have the globules of the parotid peeping out. So when we get back and when we start closing, that parotid mesentric fascia has to be closed very tight. It is here where we, without awareness, if we leave it loose, we might have those salivas seeping in and collecting it as a siloseal. So if these two things are followed strictly, I think we will never have a siloseal. Even if we have a siloseal, it is not a cause to worry. All that you can do is postoperatively, if you have a swelling, you can confirm by just aspirating and checking whether it is saliva. Second, reassuring the patient, aspirate it and then reinforce it with further elastoplaster or dynoplast. It will settle down in a week's time. This is how it can be safely managed if major rupturing or butchering of that area is not done.
Yeah. So, yeah, that's true. Manju, I am sure you won't disagree with him.
No, definitely not. The see what exactly happens is that the enthusiasm, what we or the carefulness, what we have to when we to reach the condyle, and after the fixation, sometimes we lose that concentration. So you end up closing it faster. So that is where it happens. Many times what happens is the surgeon goes and assistants of the PG start suturing. So many times what happens, we start with a proper approach layer by layer, but as the sometimes many times it happens when we reach, sometimes you're not able to see the condyle properly, or you're not able to visualize properly, so you end up releasing it more and more. So all this will happen in a layers in a different levels. Yeah, the same, okay, now you're done the procedure, you're secured, you're done the fixation, but now you need to do a proper suturing, as Dr. Ram said, layer by layer, because these layers gets retracted, and you're not able to know unless and until you care for that, and then recognize these layers and give a good suturing, you will not have this problem. Okay.
Yeah.
And if it happens, yeah, it can be manageable, but sometimes it's very embarrassing that patient keeps coming at you and kind of a thing that
Exactly.
keep changing the dressing and kind of a thing. So it becomes a little bit of embarrassment that every time he has to come,
Quite
and
painful also for the
yeah, it's
patient.
quite painful. And then sometimes you're in a dilemma whether to close it or use other methods, dynaplast, or anti-sialogogues and all that kind of a thing. So anyway, this is becomes unnecessary prolonged. So only way is better is to prevention. Prevention can give a good layered closure, will help to prevent.
Absolutely. Kannan, I want you to
Yes, sir.
answer this particular part of salivary amylase, and then I'll continue with you with the next complication. So your thoughts on salivary
Yes, sir.
amylase?
Yes, sir. Just to make sure that we have the salivary collection. Post-operative, we have a swelling in that region because of the collection there. And just to confirm, we can aspirate the content and then send it for a biochemical assay, confirming it is to be a salivary. So once it is confirmed, we can aspirate all the contents and give a dressing in that area with some anti-sialogogues will be more helpful, as some anti-sialogogues and compression dressing with dynaplast will be more of helpful, sir.
Okay. So why I want you to stay back is because the next complication that we are going to discuss is avascular necrosis. This is something which I have not seen in when we're managing trauma. And Manjunath, the other day said that it's usually something that could happen during orthognathic surgery, which is totally undesirable. So can you weigh in on this particular part of avascular necrosis, like about the
Yes, sir.
septic? Yeah.
Yes, sir. So avascular necrosis, we need to see whether it is septic or an aseptic, sir. So if it is a septic due to infection, and if it is aseptic due to lack of blood supply to those areas, we get those necrosis, sir. And most commonly, what we see is among the edentulous mandible in old age patients we see, but we have seen in a case of middle third also, maybe most probably due to lack of blood supply through the palatal vessels. And the same case, yes, sir, similar to this. There's a necrosis of both the middle third on the right hand side, the left hand side, and there is complete necrosis of the bone, most likely due to the lack of blood from the palatine vessels would have got severe, and then this patient would have got operated for the fixation of the leaflet fracture, the other areas. So again, depriving the segment of blood supply both from the external and from the palatine sources, which is leading to the necrosis. And when talking about avascular necrosis, if it is a very minimal, we can do a debridement and then give a soft tissue closure. But in this case, it is quite extensive and may have to go for removal of the bone and reconstruction. That is, curating entire bone out, resect bone, and then reconstruction. Maybe the option would be from a simple obturator to my reconstruction, free flap, maybe from the bony part from iliac, and then the soft tissue maybe from a radial flap would be more of helpful in reconstructing this. And that's about this case. And when we talk about the mandible, it is more what we see is in case of edentulous mandible, where we lose all the teeth, the endosteal blood supply comes reduced to do an open reduction for such cases of more of periosteum. When very elaborately, the periosteal blood supply to the segment is also compromised. So such cases can go in for anastomosis. So we need to be very careful in stripping the periosteal supply and maintaining the periosteal blood supply in such cases.
Yeah, that's right. That's fine. So this is what you talked about, actually, all about it. I'm coming to you, Deepti, now. You remained quiet for a very long time. So Deepti, these are condylar fracture complications. Um, you know, we can see the slide over here. So which is the one, no guesses for this. What is one of the most common condylar fracture complication that you can come across? I've given the
I
answer
would
here.
say the most devastating would be, we've gone through most of the condylar complications, condylar fracture complications, but I would say the worst thing that could happen is a TMJ ankylosis, sir.
Yeah.
That is quite bad. It could be either fibrous or bony. It's basically an addition of the anatomic joint components. And we have a case here of a young girl who had sustained a fall from a height 2 years prior. Though the fractures of the body were treated, the condyle was not treated at that time. And she presented to us with total inability to open her mouth. Now we can see the CT axial views where you can see the huge bulk of the malformed condyle or the ankylotic mass can be seen in both the joints. In the lower section also it can be very clearly seen. Well, this needs a lot of planning, a lot of preparation. We have to first see the ankylotic mass on all the coronal, the sagittal sections. It can be seen here. Here we can see that the lateral part of the ankylosis can be clearly seen. Almost complete fusion can be seen on the lateral aspect. And we should be aware, the postgraduate should be aware of the various classifications that can be asked for your viva. There are a lot of classifications. The older ones by Topazian, Sony, and Turlington and Durr. There is another one by, there's a radiological classification that is very useful for the surgeons. It's by El Hakim and Metwali. That tells you how the condylar mass or the ankylotic mass is related to the important structures, especially the internal maxillary artery. There are newer ones by Hay et al. And Yan et al. So once you have diagnosed that it is an ankylosis, you can move on to your treatment planning and your investigations. Basically, you need an OPG, you need a CT scan, and sometimes if you're afraid of the relationship between the internal maxillary artery and the ankylotic mass, you can even think of a CT angiogram, because sometimes in some ankylotic masses, the maxillary artery will be inside the ankylotic mass. So that is a recipe for danger. So it is good if you know about such things. Then one should be aware of the Caban's protocol that was formulated in 1990, but he himself modified it sometime in 2009 because he wanted to take into consideration the growth, the fourth dimension, the growth of the child. This is basically for the younger age group. And after discussion on the Caban's protocol, I think you will be asked questions on approaches. Again, we have discussed extensively on the preauricular. There are other approaches like the post-auricular, the endoral, the rightidectomy incisions, and there are various modifications like incisions are there, like Dingman, Blair, Thoma. So you will be asked questions on the pros and cons on such of each and every approaches. So in some approaches, for example, if you were talking about the rightidectomy incision, then one thing you can say is that, you can see the identification of the seventh nerve is very nice in this particular approach. But again, there are people who prefer the endoral approach, but unfortunately, they carry a high risk of perichondritis. So you'll be asked to compare and contrast the different approaches, and the Popovich's modification of Alcaid-Bramley, so on and so forth. Now, after that, probably you'll be asked about what to watch out for. What are the dangerous things that come in our way? our facial nerve is there. Then you have the auricular temporal nerve. You have the middle meningeal artery. That is something that we have to be very careful while doing the ankylosing mass resection, because it lies very close to our mass. Then you have the internal maxillary artery. Sometimes even the IJV and the carotids also have been seen in close vicinity to our ankylosing mass. And how important it is not only to preserve your facial nerve while dissection, but also to retract, use a condylar retractor properly so that you don't end up in massive bleeding from the maxillary artery. Then you may have a venous plexus bleed that can be managed by packing. So all these things one should be aware of, both as surgeons and as postgraduate students. Then there are a number of beautiful studies that one can refer to. The first one is the cadaveric study by Alcath and Branley in 1979. There is another MRI study by Miloro et al. This is all regarding the facial nerve. So once you go through all those studies, we ourselves will be confident to work on the patient once our theory knowledge is good. Then how to identify which part of your facial nerve has undergone trauma. Suppose it is a temporal branch, you end up in a brotorsis. Suppose it is a zygomatic branch that is gone, you end up in a orbicularis oculi paralysis. How do you manage, I mean, if you have an orbicularis oris oculi paralysis, all those things are important. Then, sir, shall I proceed?
Yeah, go ahead. Go ahead.
So then we can talk about the various procedures that can be done. If you look at it historically, Asmark, he proposed that you can resect the ankylosing mass, but he did it right at the condyle, at the angle, and he placed an interpositional material that was nothing but the pterygomandibular sling. So after that, of course, it is not done nowadays. But now what we usually do is a gap arthroplasty. It has its pluses and minuses. Of course, gap arthroplasty is very rarely done. Now what we do is an interpositional arthroplasty. The difference between gap arthroplasty and interpositional arthroplasty should be understood. What are the interpositional materials that are used? And if you look at the classifications, especially the one by there is He et al. In 2011, they have also suggested a procedure called the lateral arthroplasty. Like, see, we have the condylar, the ankylosing mass will be as two bulbs. Usually what we see is the lateral part of the ankylosing mass, that is the one that has bony connection, but the medial side, there will be a false joint space. So in young children especially, we can go in for a lateral arthroplasty where only the lateral part of the ankylosing mass is removed. And the rest of the condyle, that actually serves as, becomes an almost normal condyle as growth catches up. So that is what the literature says. And we should also be aware of the various soft tissue interposition materials. All-time favorite is the temporalis myofascial flap. It can be taken in, it can be accessed by through the same incision as our surgery. Then we have dermal fat grafts from the abdomen. The only thing is you have to oppose the skin side together and keep it inside. The buccal fat pad is also another very useful interpositional material. That can also be on the surgical site itself. It lies very close to your area of coronectomy. Some people suggest amniotic membranes that are gamma sterilized. And of course, the Gallia flap also can be used, but that is quite thin. So it may not function, it may not serve a function. Again, we can talk about hard tissue interpositional materials. Gunasheelan et al., they have suggested the ankylosing mass itself can be used as an interpositional material, hard tissue material. The only thing is, for practical purposes, it may not work, because when we take out an ankylosing mass, none of us really take it out in toto, because we are scared to do that, and it is not wise either. So we take it out in pieces. So unless and until you get the ankylosing mass in toto, it is not practical to use it. But still, that is a very good interpositional material, because you don't have to take it from anywhere else. Then the costochondral graft.
Dipti, if I may interrupt, Bhagwan, there's something that I would like to add here. Dr. D.K. Gupta does,
I was about to come to that particular point. because with all due respect to Kaban, the
Yeah.
number of cases which protocol has proposed is a very small number, whereas Dr. D.K. Gupta, sir, in Jaipur, over their vast series of 700 plus cases of ankylosis, where the medial condyle displacement of the condyle probably would have led to ankylosis of the joint. They are not removing the condylar part of the medially displaced condyle. They are removing the ankylosed part of the bone, releasing that particular thing, and still using the same condyle which is there, though it might not be a functional joint, but probably it might help in some amount of vertical dimension of the ramus condyle unit.
Yes, yes.
Yeah. So that is what I wanted to add,
Yes, sir.
because
I
sir
think,
has done. Yeah, go ahead, Dipti.
yes, sir. Sir, and in children, we can go in for costochondral grafts. Even the coronoid can be used as a graft. Once you do a coronectomy, that can be used either as a free graft or it can be used as a pedicle graft. So then it won't dissolve. So
Okay.
those are the interpositional materials. And finally, we can move on to adjuvant procedures also. We have, of course, in this particular case, there was not much of a posterior facial height problem. But in cases where we have that, we can go in for a vertical ramus osteotomy, an L ramus osteotomy, go in for a distraction osteogenesis of the ramus, of the posterior part of the ramus. And in adult cases, when there is reankylosis, the best thing would be a total joint replacement, though it is not advised in children because TJR is not usually advised because it has to be changed as the patient grows. So these are some of the points that we should know when we think about the TM joint ankylosis.
Yeah, thank you, Dipti. Our next and last complication is on zygomatico-maxillary fractures, right? And that is something we come across so often. And Ram, I'd like to put this across to you. This is a case, that we have. A 19-year-old male complains of double vision, inability to close the left eye, and frequent tearing. Of course, the victim was of an RTA. He sustained head injury and a comminuted left zygomatico-maxillary fracture. Now, this is what you see. Okay. So, how would you get about managing this case? I'll show you the X-rays also.
Yeah, just one question in this: is this pre-operative or post-operative
So
situation?
this is post-operative, sir.
Okay, so maybe we can understand it is a slightly mismanaged case.
Yeah.
Because orbit, if we really understand, it is a three-dimensional structure with involving 7 bones in its constituency. So
Yeah.
if we are not able to three-dimensionally, vertically, transversely, and anterior-posteriorly reconstruct it, we will not get the globe in position. So the key here is going to be the diagnosis with proper 3D CT scans, orbital sections, the functional component of the eye movements, everything. Once that is done, then let me see the X-ray, the CT, and then
Yeah.
talk.
So this is the CT. You can see
Oh,
him
this is
here.
a managed one. I can maybe we can even see mesh that is literally protruding superiorly instead of staying in the floor. So this is exactly what we are trying to say. You look at the right side orbit, the normal orbit, look at the shape of that, look at the circumference, and then compare it with the left side. Left side, there is totally no continuity of, forget the bone, any hard tissue along the floor, and it is completely splayed. The zygomatic prominence is completely splayed. There is a clear dropping into the antrum. So naturally, this globe cannot stay in position. There will be a hypoglobus situation. Naturally, there will be a diplopia, and depending upon the injury to the lacrimal apparatus, they can have tearing or they can have pooling of tears and crocodile tears. So all that is possible. Ideally, what should have been done in such a case of a complicated zygomatico-maxillary or orbital fractures, if we are not sure of reconstructing the floor, in today's world, if we can do a three-dimensional reconstruction using an analog, that is the stereolithographic model, we can duplicate the normal side to the abnormal side and recreate a left side as if how it would have been in the past, and then adapt your mesh and then be prepared. If you are not planning for a PSI, bring that mesh to the table and then try to reorient as much as possible close to the near normal. That is how we should approach. And keeping that in mind, whatever relevant surgical approaches is necessary, whether it is a lower eyelid incision or a transcaruncular incision or a canthotomy extension, all this has to be planned, and then the entire orbit has to be completely reconstructed along with the frontozygomatic sutural area, and then come down to the zygomatico-maxillary junction, and also keep an eye on the arch, the zygomatico-temporal extension. If necessary, even that needs to be opened with help of a Alkayat-Bramley or a preauricular approach, completely exposed. Make sure the anterior-posterior extent of that part of the zygoma is re-established, and only then we can have a three-dimensional reconstruction of this important anatomical structure to avoid any sort of complication. Whatever functional residue is left behind, we have to wait and watch. So this will be
Right.
my take and approach.
Dr. Manjunath, won't you agree that basically from what Dr. Ram has said, that it's the basic treatment goal would be to restore the facial projection and symmetry?
Yeah, definitely. Function as well as aesthetics, both needs to be taken care of. Yeah. Now, yeah, sometimes we blame we say mismanagement. Many times what happens, we don't know the consequences or what exactly, how bad the injury would have been, how complicated the fracture would have been. Sometimes it's impossible. So in some cases, a bad result or a secondary deformity is expected. But yeah, as Dr. Ram said, if you prepare well, if everything goes fine. In this particular case, if I one more thing is the injury to especially the lower eyelid.
Yeah.
The lower eyelid is the one where scar is the one which is making it appear very bad. Now we can restore the rest of the part, and maybe I feel there might be if you go for the clinical picture in that, maybe there might be some amount of nerve injury, because you can see some amount of ptosis also in the so there would be a combination of nerve injury, the skeletal issues where the volume has been not been restored, and as well as the lower eyelid injury. So all
Yes.
Entropion
it's
is
a very
also
very complex problem. It's not
Very
just
complex.
very complex, not just
Ideally,
alone the
yeah,
hard
ideally
tissue and
maybe
all.
the lower lid reconstruction also would have to be
Exactly.
planned.
Correct,
There is
correct,
literally
yeah.
no lid.
So,
No,
so
no,
this
no.
is, so is this entropion or ectropion?
There is no lid, so you can call it.
It's entropion, sir. It's entropion. Yeah.
Okay. So could you just throw a little more light so that our residents they get enlightened?
Sir,
Entropion
actually, entropion is when the eyelid actually falls. I mean, the eyelashes are almost onto the eye. That is what is seen over here.
Yeah.
So here, like it was said, there is a lot of damage that is done to the lower eyelid, and that has to be corrected. If it was something minor, we could have inserted sutures like the Quickert sutures. That is, you just put a 5-0 suture into the inferior fornix, and you pull it out, and that will cause some sort of an eversion of the lower eyelid. But here, I think it's gone beyond that, and we have to think of a graft and even tarsal plate in a way. I mean, things like graft from palate or from the cartilage, that should be inserted, because otherwise, I don't see any other way how this person is going to get it all right. So that could be a solution to this particular case regarding entropion. On the other hand, if you're talking about the opposite complication, that would be ectropion, where it just stays outside. It's the reverse. It's just it's outside. The lid doesn't. The lower lid just stays away from the eye. In both situations, we are going to end up in corneal abrasions and possible blindness. So it has to be addressed pretty seriously. So for ectropion, we can think of tarsography, the temporary tarsography, or frost sutures. Again, we have, those are things that are usually done for ectropion. And there are procedures like the waist procedures. I think those are purely plastic surgery procedures. I'm not very sure how to explain it, but those are the procedures that are recommended.
Yeah. So I think now the last point that I would like to ask our panelists a few causes of blindness. One important thing is that, which you have addressed, Dipti, is when you treat the white eye, if there's a white eye fracture, right, and the oculocardiac reflex. So maybe just if you can just throw a little light on the oculocardiac reflex, and then we talk about the cause of blindness.
So the ocular cardiac reflex, well, we see it even while we
Manipulate the
we are
fractures.
quite familiar with the ocular cardiac reflex, because
Yeah.
yes, that is, even when you do a zygoma elevation, well,
Yes.
it can happen. Anything that you do on the midface or around the eye, well, you can expect it. And if it is done, when it's done under GA, well, I mean, what can be managed? It should be managed, because bradycardia is going to be potentially dangerous.
Yeah.
So fluids should be given. Atropine is supposed to be the 0.4 to 0.6 milligram of atropine is the, I think that is what is recommended treatment.
Yeah.
For this, if that needs to be given.
Yeah. Because basically we should, inform the anesthetist that we are going to perform this procedure.
Anesthetist, yes, sir. Yes, sir. They should be aware that we are going to move it. We are going to move the midface.
Yeah. See, there was a very important point that was raised in the chat. I think we should wind up our case discussion right now, because we are well past the time. And there was one important point that was raised by one of the attendees, was that borderless triangle, right? Borderless triangle is a very important landmark for the ease of identification of facial nerve trunk during parotidectomy. So this is something that's very important. And the first line runs from the tip of the mastoid along the superior border of the posterior belly of the digastric. The second line is the posterior border of the ramus, and these two lines intersect and form an apex of a triangle. So the base is formed by the tip of the mastoid till it meets the second line. So this is a very important point that one needs to keep in mind, and it's more of interest because it's by one of the most talented and a very a legend amongst us, that is Dr. Rajiv Bodle. And Dr. Abhay Kamath has also given very important points, which I should deal with you at the end of the presentation. So I think this is, at this point, we'll wrap up our discussion on the complications. We've got more coming up in just a while. And I would like, now I'll stop sharing, and I'll now invite Dr. Bhagwan Das to start his presentation on practical tips for examinations. If people remember, we had this discussion with him during one of the CIMS webinars somewhere in the month of August, I think. So Bhagwan, it's just a quick recap from you.
Okay. I'll take around 8 to 9 minutes probably. Just a minute. So when I'm thank you TNAMSI for this opportunity. Very quickly, preparation for an MDS examination, when I'm talking, this particular batch is the first batch of MDS, probably, which will be giving only 3 papers in their final year exams. Till now, it was 4 papers which used to be given. And from this is the first batch which will be giving 3 papers only, because they have already given their part 1, paper 1 of 100 marks in their first year, end of first year. So if you see for the preparation, it's a theory paper preparation and a practical examination. Theory, already the part 1 is over. The part 2 is end of 3 years. What is there is the paper 1 is minor oral surgery and trauma. Paper 2 is maxillofacial surgery, and all these papers by and large, as guided by the DCI, it is 100 marks paper. Earlier, some university used to have it as 100 and some university used to have it as 75. So now it is 100 marks paper, because this final year paper is for 300 marks. The paper 1 and paper 2 has 25 marks each, 2 questions, and 5 questions of 10 marks each. So 50 of that and 25 into 2, 50 of this makes it 100 marks. Whereas the paper 3 essay till now used to be one single question. Out of the two, you had to choose one. So that used to be quite challenging also. And people did it and we all did it. But now they have simplified it. Having two questions has to be answered. There will be three questions. Out of three, the two has to be answered, 50 marks each. That's about the theory paper, which we all have to be aware of. I won't go much into detail of that. When we talk about the practical examination, it's a 2-day program, as we all are aware. One is a minor oral surgery, which consists of 100 marks, and the case history part, which is there of one long case and two short case. So that is of 100 marks. The long case is of 60 marks and two short case of 40 marks each. That's on the day one of the practical examination. And then the second day will be viva voce and pedagogy, which is again divided between viva voce as 80 marks and pedagogy of 20 marks for the second day. So when I'm telling this practical viva voce, I want to stress one point. I hope if a lot of examiners are also listening, because we don't tend to change. The DCA also says the viva has to be conducted as two teams. Team 1 and Team 2. Team 1 has to conduct it for 40 marks and Team 2 has to conduct it for 40 marks. It's how that the candidate goes to both the place so that all the topics are covered. So coming to the practical examination, when you are having, it's mainly for assessing the competency of the candidates, the skills and techniques of the procedure, the ability to make relevant and valid observation. I'm talking about both the surgical as well as the case history discussion, the ability of the interpretation and inference of the lab reports, experimental or clinical work related to the field or the subject. So of course, we all have to remember this is a master's degree, and this is the highest degree as of now, which is there in the maxillofacial surgery field. The preparation has to be according to that, and assessment also will be involving this. When talking about the minor oral surgery of 100 marks, which is there, includes removal of the lower third molar, which by and large everywhere it is followed. But we also need to know that there is other procedures can also be involved as a cyst enucleation or any other similar procedure. When I talk about any other similar procedure is where the professional skills of raising a mucoperiosteal flap, removal of bone, and the suturing can be assessed. This is the tissue handling, everything comes into that. This is as per the Dental Council guideline, which we are most of the time not aware, or we don't give emphasis on that. We tell ideal third molar has to be removed, or sometimes it is told that only a third molar which is submerged has to be removed. Given a case, it has to be managed. So how to prepare for practical examination? So as I told, this particular thing is day one is a surgical minor surgery procedure and case history. So surgical removal of impacted tooth, you need to take a brief case history. Your diagnosis has to be precise regarding that particular condition, and the management planning has to be there, and the stepwise surgical procedure has to be planned, and if when asked, you should be able to explain that particular thing. So when I am talking about stepwise surgical procedure, which is there, when you have the case history, which is there, this for total 100 marks paper. So case history, the anesthesia technique, the incision, and which is there, the marks can be divided like this for the bone cutting, odontectomy, suturing. So while doing a procedure, suddenly probably if your flap gets incision or reflecting of the flap is somewhat there, you need not have to be tensed that the whole exam is going to, your whole procedure is going to be. See, you will be assessed for your odontectomy, how you are going to section the tooth, whether you have planned earlier like that. The same thing are you going to do, and finally how you're going to suture. All these things are taken into consideration. So that has to be kept in mind. So other important thing is a proper radiograph before the procedure is started, because these cases are to be brought by you, or by and large it has been called for the day of examination. Tracing and difficulty score has to be assessed. Having said this, spare case should be there for selection, for the examiner to select the case. So this is also needed. Check the instrument trolley, that all the instruments have been kept for the for the procedure which has to be done. This time, probably due to COVID, most of the places this particular step was avoided, and certain places it was followed. But definitely by next June, I think earlier the exams can happen, because last year we had 60 days off. So ideally it will come in June. So I think by June this time we'll be able to conduct the procedure on the patients as usual, which used to happen. In the case history, after noting everything, the prescription and the instruction also has to be put, because what you are going to prescribe and how much you are going to prescribe, that also matters. So that is also an important part which has to be uh, taken into account. Then coming to the case presentation, a long case and two short cases there. Long case is for 60 marks, and the short case, two short case of 20 marks each. So in this, when you see case history has to be noted properly, differential diagnosis has to be there, investigations required, and the management planning. Whether it's a long case or a short case, these are the 4 points which will be assessed. So if you see how it is, marks can be distributed when you go into the exact part of it. For a case history, you can think of 10 marks, the investigation of 10 marks, the differential diagnosis 10 marks, the management planning of 20 marks, and the discussion of 20 marks. So this is for a major case which has 60 marks. So you should be able to concentrate equally on all these points: the differential diagnosis, the management, the discussion part, how you're going to take the discussion while answering. So that you need to think. Short case, two short case are there. So again, it's 20 marks each, but the contents will be same: the case history, investigation, diagnosis, management planning. So you can divide the marks as 4 marks for case history, investigation, differential diagnosis, management planning, discussion. So this is how you try to have the first day of the examination, and this is the preparation you need to have, and this you have to keep in mind when you are taking the case history. The case history ideally usually given is around 30 minutes for a major case, 30 to 40 minutes, and for a short case, 15 to 20 minutes each for recording the case history. So hopefully next year you will be ideally taking the case history on the patient, which is there. But after the patient, if it is relieved, if there is a PPT, it will be ideally better while conducting the examination. Coming on the second day, viva voce and pedagogy, which is there, 80 and 20. Viva voce is conducted by the panel of examiners. So one panel can be one external, one internal, and another panel can be one external, one internal, which will be conducting for 40 marks each. The whole purpose of this viva voce is to see the comprehension, analytical approach, expression, interpretation of the data, and communication skills, which is there. Includes component of the course contents and the discussion on your dissertation, if you have done, and if it is there. That can be discussed, because in the earlier times, the examiner itself used to evaluate the dissertation, and now the dissertation goes somewhere else, and the examiner would not have been having an idea of the dissertation. So it can also involve in your this thing. While coming for the viva voce, I think one important thing is which every exam going postgraduate need to know is his particular question paper. He need to be thorough about this, not to forget brushing up of his question paper. Not necessarily that the examiner will be having his paper. It can be anybody's paper if it is a pooled correction which is going on, but they will be just going through the question paper in the previous day or on that day there. So usually there is a chance of asking the questions from the question paper if the candidates have not performed well. So you cannot leave that part not answered after the theory exam, even in during the practical examination, viva voce. Then the regarding pedagogy exercise, which is there for 20 marks, A topic, a simple topic is given at the beginning of the clinical examination, the first day itself, and the presentation of 8 to 10 minutes. So usually this has been done to elicit the teaching skills and the presentation skills of the candidate. Hardly the question pertaining to the topics are usually not asked during this particular thing. It's for 8 to 10 minutes. You can ideally, the students can be called or an interns can be called, and the particular candidate can be asked to take the class. And in 8 to 10 minutes, how he has covered the topic, how he has presented it, how he has ensured that the audience have got the glimpse of what he has explained, and how he has evaluated what he has told has reached to the candidates is evaluated in this pedagogy exercise. Coming to the last part of it, probably one important thing is for the practical examination, which you need to remember is postgraduates should be very familiar with the textbooks which they have read. If they are telling this is from this particular textbook, which will help and impress the examiner that the preparation have been ideal, because especially the edition, it's not that which edition. I've just given few of the examples of the books, and at the same time the journals, because it has so happened that name some textbooks which you have referred. Some standard textbook, if the candidate doesn't name, there will be a lot of disappointment as an examiner, if you ask me personally. And journals have been asked, if you're not able to name some 8 to 10 journals, that's also quite bad impression on the examiners. So I think this is very quickly and briefly, which I could gather given time for the MDS examination. Thank you, everyone.
Bhagwan, thank you. I remember when I had come to Udaipur in 2011 or 12, you had the two-station Viva and the topics. I still have that in my mail. And sometimes when I go to some place, some new place, I always carry it with me so that, that doesn't allow
No, that has been recommended by Dental Council.
Yes, yes. And you've been doing it
it's
much
there
before
gazetted.
that.
Yeah.
You've been doing, so you are far ahead of, in the thinking process.
Thank you.
So Manju, we are going to come to you for a journal club presentation, which is also very important postgraduate activity. So
yeah, I've shared my screen. Is it fine, Dr. Shanai?
Yeah. Can you, this is the maximum size, or can you increase the
full screen? Full screen.
Yeah.
Can be done.
One second.
Slideshow.
Maybe you could increase
play button.
Sorry.
You go
play
to the
button. Yeah. Is it fine?
You go.
Yeah.
Is it fine?
Yes.
Okay. Yeah. From where, I mean, obviously, Bhagwan would be a very ideal examiner for most of the postgraduates. So he has. And from where Bhagwan left, now he mentioned about one thing about the pedagogy, and he said about how your skill of presentation and this would be assessed. So now it doesn't happen overnight. So these things actually develop over a period of post-graduation. So one of the important aspect of it is, other than the seminar presentation, is the journal club presentation, which in every college does it. So there are few points or tips which I would want to mention in this particular presentation. Okay, now coming to what is journal. I mean, so I'll be presenting under this following heading: need for a journal club, aim of a journal club, types of journal clubs, tips for presenters, and impact of journal club. Yeah. Now, what is a journal? Journal in a normal scenario, it mentions it's a periodical publication. It's a common, like aimed at particular discipline. It could be medical journal, it could be dental journal, it could be any other society's journal. So basically, it's a periodic publication which comes regularly. Okay, and what is its intention? Yeah, it is intended for the specialists to stay updated about the development in their field. So anything whichever recent relevant things whatever happens, and the journal, a reputed journal, which when it publishes, there are so many readers are there, and so this is how you keep abreast with your latest things, whatever is happening in your specialty field. So, in journal term, what is a journal club? It's a group of individuals who meet regularly to critically read, understand, and evaluate recent articles published in medical or dental literature. Okay, so it's nothing but a group of individuals. We meet for a particular purpose. So the purpose on that day is the presentation of a journal. Okay. Now, question is, what is the need for a journal club? Okay, it is a forum to remain updated with the current literature and to learn methods of critically evaluating journal articles. See, most of the time, how it is different from the normal seminars. Here, normal seminars will be, obviously there will be moderator and the presenter would be there, and when the questions goes to the all the participant. Whereas here, there is much more than that. Here, the everybody gets involved, and you critically evaluate the particular article, and then the lateral thinking, these things which will improve. And also, journal clubs are usually organized around a defined subject on in basis of applied research. So if you want to know something which is recently happened, and because you select a good article, and then when that is been that been presented, there will be so many things where the questions will arise, and the way of assessment of that article will come in this. And yeah, and why do we aim? What are the aims of the journal clubs? No, it's improve the clinical practice and application of evidence-based medicine. So many of there are different types of articles comes in a journal, whether it's a review article, whether it is a, uh, 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 letter to the editor. There are many type of clinical note. There are multiple type of things which articles will be published. So we need to see how which are the one which is suitable for to present. And it also allows academic debate and networking between the colleagues of varying seniority. So there might be somebody who's very senior, somebody who's recently passed, but they have much updated. So you will discuss a lot of things during the discussion. But a lot of these things will come, and also to discuss and apprise the medical literature, which will help postgraduate students to develop a critical appraisal skills. So it will help them to develop these skills, and also to develop research ideas stimulated by articles written. So you are also doing a thesis as a part of your requirement of your MDS. So when you are doing it, and when you're in the future, when you're going to write, these journal clubs or the which will help you, because you're reading that, you know the process, you know how to write. So this will improve your skills even as far as the, and also it will prepare you to write some articles to the other journals. And types of journal clubs. Okay, now there are few journal clubs are aimed at knowledge, updating the knowledge related to the field of interest. It could be implant, it could be TMJ or arthroscopy, anything. So which field of interest can be picked up, and then we can give that particular topic. Aimed at updating clinical practice. The recent developments will happen only when we present this journal or the good article from a good unit has published something which is new, and that can be taken up so that your knowledge is improved. Aimed at teaching and learning, though it was initially started as a teaching only method, but here you're going to learning a lot of critical appraisal technique in these journal clubs. And also we learn about this problem-based journal clubs centered on a particular problem. So these what are the benefits of journal clubs? Now your clinical appraisal skills are developed. Participants will keep abreast of the current medical literature. Research, literacy, and evidence-based practice are developed. The needs of continuing medical educations are met. Interview skills are developed. When you're asking questions, when various types of your interview skills will improve. Academic debate is stimulated, and interdepartment social and professional networking takes place when you have interdepartment meetings in the JCs. So publications are generated. So when we read, when we've seen how it's been written, or how the methodology has been formed. We learn the knowledge or the way how the wording should be there in a journal, and this will improve our the way of writing and publication method will improve. So few tips for presenters. So it needs to be articles. The postgraduates will select few articles and go to the PG guide or the head of the department, and then they will select topics in that particular thing. One or two they will pick it up, and this approval should happen over a period of time. It's not just very short period. It should be happen, let's say 2-3 weeks before. Presenters should plan it well ahead, confirm the presentation on a particular date. Articles should be handed well in advance. It's not just you give it on the previous night and they wouldn't read it, and they just come and read it along with it. That's not the way. It should be given to them well in advance so that they understand it and they're prepared for it. So the chairman, you can have a chairman, you can have the chairman would lead, head this one, define the goals. What are the things and optimize attendance, generate participant interest. We need to, in the beginning only, brief thing about the journal has to be mentioned. What are the points they wanted to prove? What are the parameters they use? Few things can be initially, and with the methodology, everything can be, critical appraisal can be generated in that particular journal. Yeah, how when you're presenting, what are the guidelines? Introduction, a short review, presenting and evaluating the data from the research article, briefly outline the experimental design of the paper, by using the key figures from the paper, how they support the conclusion. Now, and one more important point, what when you're presenting is, it is somebody else's presentation. You don't need to defend every part of the journal club. It is somebody else's. So if you always say that authors concluded, or according to the authors, this is what this is what they did. You don't have, even though you are the presenter, you don't need to mention that as if it's your study. So that is how we need to do it. Yeah. It includes how it should appear, title, author and place of work, introduction, material methods, results, discussion, what question to ask, and general rules. So how does journal club, the impact of the journal club? Okay, so it improves reading habits by enabling critical thinking. It expands the body of knowledge within a person. It facilitates acquisition of new skills. It induces scientific temperament by promoting questioning attitude. It improves knowledge of clinical epidemiology and biostatistics. It makes the member more to be more skeptical of the author's conclusion. So when you start asking questions, yeah, maybe tomorrow you might become the good examiner also. So this is what is the impact of the journal club. Communication skills are the key to keep the audience engaged. And I would like to conclude by quoting Swami Vivekananda: knowledge can only be got in one way, the way of experience. There is no other way to know. And I would like to extend my thanks to Tamil Nadu MSI and especially Jimson. They have been doing wonderful. Every week they have been doing this particular thing. Hats off to Tamil Nadu MSI. Thank you.
Thank you, Manju, for an excellent, superb presentation, as usual. And now I would like to call upon Dr. Deepti Simon, who's going to talk on thesis presentation. The 2018 batch and the 2019 batch, better keep your eyes and ears open. And of course, even the 2020. Go ahead, Deepti. Deepti is a PG scholar par excellence. Following this, we'll have Dr. Ramkumar on what after MDS? Big question. I'm sure Ramkumar is going to solve a lot of queries. And then the last one would be by Dr. Kannan on paper presentations. Manju and Bhagwan, you're right. What the TN and Puducherry AMSI has done is it's a service to maxillofacial surgery. Deepti, if you're having an issue, can we have Ramkumar?
Is it? Yeah, sir, please. No problem. Is my screen visible?
No.
No, screen sharing has not been done.
No, okay.
Can I share the screen?
Yeah, sure, sir.
Jimson was unbelievable. He was doing a lot of things when he was in Australia, stuck in Australia.
Yeah, exactly. I was about to say that itself.
Oh, great going, Jim.
Thank you.
Okay.
Yeah.
Dipti.
So can I start?
Yeah.
Yeah. Am I audible?
Yes.
I guess this is one thing everybody wants to skip during their MBS course. Most of us, even when I was a PG, I thought about it as a terrible, horrible headache. But unfortunately, it's mandatory. I don't think there is any place in India where we can do a MBS degree without giving in your thesis. So unfortunately it's mandatory. It's more or less like a rite of passage, and it ends up being an arduous process. Usually it starts with a lot of noble aspirations, and when I was a PG, I thought my thesis would just would contribute to the literature and etc. But most often we don't end up in, even though the aspirations are high, it just ends up as a hardbound book that is given to the university, nothing more than that. But it has to be done, and the best way to do about it is to go about it in a very, very systematic manner. The first thing is we have to understand the difference between a thesis and a dissertation. We do have dissertations also as part of the PG curriculum. A dissertation is nothing but a review of literature. You don't have to put in any of your original work. You just select a particular topic, and you collect all the relevant literature, and it's compiled. On the other hand, the word thesis comes from the Greek word, it's called tithanai. It means to put forth. So you're putting in something. There is some personal. You are contributing something by doing something, either, whether it's, a study that is, just observational or interventional, whatever it is, you are contributing something. So basically the Oxford English Dictionary defines it as a long essay or a dissertation involving personal research written by a candidate for a university degree. But again, you have a personal contribution. That is how it differs from a dissertation. Jim, sir, the next one. Like I said, it's mandatory. But what are the advantages? Even though you're forced to do it, unknowingly, it helps you to do a lot of, it gives you a lot of skills. For example, it helps you learn the art of doing research. It is only very few industrious children do it during their undergraduate days. So most of us, we learn the art of doing research only while we are forced to do it, and that is via the process of doing your thesis. You can understand the process of research methodology. It cannot be done haphazardly. There are certain ways to go about it. And even later on in your career, when you start reading an article, you need not believe whatever the writer or the author has said, because through your process of writing a thesis, you have learned how to critically appraise whatever data is given in front of you. You need not believe it blindly. And it helps you to become more systematic. It helps you to collect and record data, starting from photographing the patient or the CT scan, or recording the data on an Excel sheet. So all these things are learned by the student unknowingly. It's not a formal way of learning it, but unknowingly you start doing all these things because you're forced to do it. And finally, at the end of the day, after you've published your book, you can tell others about what you've done by publishing. So again, that helps you to write papers that can be done in parts, it can be split and written, it can be done as a whole. So these are the advantages of learning how to do your thesis properly. All these things are done unknowingly, but it stays with you. So the next slide. Jim sir, the next slide, please.
Yeah, it changed. Yeah.
So a couple of steps that we need to follow. The first thing is we choose a suitable research area. So when you start your postgraduate life, everybody has their own favorite areas. For some people, it may be pathology. Some people, it may be oncology, implants. So you can choose your own favorite research area and select that. Of course, it is also important that you should assess the availability of whatever facilities are there in your particular institution. Here at Trivandrum, we have a lot of other institutes like the Sri Chitra Tirunal Institute of Medical Sciences, the Rajiv Gandhi Center for Biotechnology, the Vikram Sarabhai Space Center. All these places, they welcome us because we do a lot of combined work with them. So if you have facilities in the vicinity of your institution, you can combine your work. For example, if you're doing something in materials research, for example, like bone grafting, hydroxyapatite, all those things, they will help you out because they have a lot of superior laboratory facilities which we can't access otherwise. So it will be nice if we liaise with other scientific organizations like that if they are available. Of course, selecting a guide or a supervisor is not a luxury. I mean, it's not available to us. We are selected. Rather, the student is selected by the guide. So this is just for selecting a guide or a supervisor is usually applicable for PhD candidates, not for the MDA students. If it's an expensive project, you can try to apply for a STEC grant or a DST grant. All these are available. And you just have to go on the websites of these organizations. You may be able to get the grants, but these things have to be planned well in advance because it takes a lot of time for these organizations to process your application. So for an MDS student, probably obtaining a grant would be a long drawn out process. So probably most of the students, they don't have this opportunity to obtain grants, but in case you're pursuing a PhD, much in advance, you can submit your protocol and obtain grants. In fact, there are researchers who've got grants up to 1 crore for developing certain techniques. Recently, there was somebody who developed a technique of detecting malignancies via saliva estimation. So markers in saliva. So those things can be done. Then coming back to the thesis per se, prepare your objectives, write your protocol, and it should be a simple, well-written protocol with the aims, the objectives, a short literature study, how you're going to do your statistical analysis. So those are the important parts in the protocol, the materials and methods. Then you will have to go to your institutional research committee or your institutional ethics committee. It has to be cleared by them. All the studies have to be cleared by them. In some cases, well, you will have to register with the Control Trial Registry of India or the Drug Control of India. If you're doing a study involving medicines, ampicillin or any other drug or any new drug, if you're trying out a new drug, well, you'll have to register with the Drug Control of India. And all other human studies are supposed to be registered with the Control Trial Registry of India. They will give you a provisional registration number at the beginning, and that will finally be made permanent. So the next slide, please. Once you have prepared your protocol, it is always wise to stick to your study design rather than deviate from it too much. In case you have a problem while you're doing your study, for example, you would like to assess the bone density in a particular lesion, and you have decided to analyze it with, counting the squares on the by using a mesh. But later on, you found out that you've got a good software like ImageJ or something like that, which will just help you to do it much faster. For example, the mean bone density can be compared in a better way. You are expected to tell your research committee or the ethical committee that you have changed that part of your study. That part of the study, whatever changes you're making in your research should be intimated to the institutional ethical committee. You usually have two types of studies. Either it's observational or interventional. That can be chosen by you and the guide. Collect and store your data. Very important. But now I guess nobody has a problem now because everything is digitized. In the earlier days, we did have a problem because the x-rays used to go bad. Nothing like that happens nowadays, but be very careful. Make sure it is always having a backup in a hard drive so that you don't lose it at the end of your study. Find out a good statistician who can do your statistical analysis. But for an MD's thesis, I think most of us can do it by ourselves because we wouldn't be doing any complicated tests. A t-test or a chi-square test, all those things, all those apps, you have n number of apps that are available for statistical analysis. But still, you can discuss it with a biostatistician for finishing, giving it finishing data. Structure the material, whatever you're writing, let it be structured. For example, when you write the thesis, you write it in 4 or 5 chapters. You first write your introduction, then you go on to the aims, then you go on to the materials and methods, the review of literature, then the results, the discussion, and the conclusion. So when you write your discussion and conclusion, be critical. I'm sure that every thesis has its negative points and strengths. So elaborate on both in an impassionate way. We don't have to defend our study too much. There are faults in every study, and it's always wise to accept that our study has its pitfalls, but you can always highlight on your strengths as well. Once you finish writing your thesis, you edit your contents. It's always nice to take a printout before a rough printout, edit the contents. It's easier done on a hard copy than a soft copy. Once you've edited the contents and the language, you have a lot of apps to edit language also, like Grammarly. I'm sure all the young ones are very familiar with such apps. Then the next thing that you have to do is, Jim sir, the next slide, please. Jim sir, the next slide. Important thing to look for is to check for plagiarism. There are apps for that, or there are centers where they do check for plagiarism. They have we here in Trivandrum, we just have to give it in a soft copy to the university, and they'll check it for plagiarism. The copyright, the acknowledgements, disclosures, conflicts of interest, everything should be specified. And finally, you give it. Your book is ready. You finish your PG thesis, you finish your MDS, but don't stop with that. Please publish it in a suitable journal, and definitely try to present your work at conferences, because I'm sure every thesis brings out something nice and something new, which the world should know. So I guess that is the end point of the thesis. It should end up in something nice, and everybody should know what it is. I wish all of you a wonderful time doing your thesis, writing. Enjoy the process. It's really nice. And let me just thank Rina ma'am, Jim sir, and Wainil, and everybody in the Tamil Nadu AOMSI for this wonderful opportunity to spend some time. Thank you so much.
Thank you, Dipti. Ram?
Yeah. I'm coming.
Yeah.
Can you see the slide now?
Yes.
Okay, so here we are. To my special thanks to our president and secretary of our prestigious Tamil Nadu state chapter, my worthy successor Jimson as secretary of the state. He's been doing a phenomenal job right from pre-COVID times to COVID times, and he is set a new trend in handling such wonderful educational programs. Only displeasure for people amongst us in Tamil Nadu is he is not giving us Pongal holidays, he is not giving us Christmas holidays, he is not letting us enjoy our weekends. We are a little bit upset about it, but that's how it goes. The choice is there: 365 days, 52 weeks. You don't have to attend everything. So in that way, we are happy. Thank you, Jimson and Dr. Reena for the wonderful job and your EC. So let's now talk something practical. I was in active academics for 18 years and 4 years now I am in full-time practice. So I thought I should give a piece of info what I have understood in this 22 years as what can life be after MDS for the budding surgeons. Okay, here we go. What are the possibilities? Definitely, yes. In today's generation, every single surgeon after his MDS has to think about further training. How do we get trained? Where do we get trained? Is a different scenario, but we need to get trained. A mere 3 years of study is not going to be enough because there is so much that is advanced, so much of info that has come into, so much of competition that is there in practice. So just having a degree is not going to be enough to rule the roost. Second, whether you're going to spend your remaining part of your life in academics or in private practice, that is a call you need to take. And third, and the last but not the least, there is an increasing thought process going on that you can still consider appearing for NEET and maybe do a medical degree, which is going to be the real thing for future. It's not out of our box. You can still qualify yourself, get your medical degree, and then this is my piece of advice for the younger generation. Next, I will categorize the entire maxillofacial surgery into three levels, which our international president, Dr. Kishore Naik, in his wonderful article has mentioned how we can categorize OMFS into three levels. One is the basic level, that is the dentalveolar surgery, medically compromised patient, and dental implants. This is a must for every single surgeon who has completed his MDS degree in India. When he walks out of after his exam, he should be qualified to do all these procedures comfortably under local or under even general, all the type of dentalveolar procedures, handle medically compromised patients in a well manner, and get more into the dental implants also, because it is not only our duty to get into the surgical part fully well, we need to understand the prosthetic part, which is very, very difficult and very, very upgrading day by day. So this is a must for a fresher. How do you get it done? Where do you get it done? Is up to you. Next is level 2. Slowly we are jumping into the breadwinning areas, that is the trauma, a little bit of TMJ, because if you're going to touch trauma, you're going to touch condyle. If you're going to touch condyle, then you can start doing everything in and around condyle. And last but not the least, in the level 2 will be orthognathic surgery, which is the unique specialty of our field. No other general surgeon or other plastic surgeon or any other surgeon will be as competent as us if we really get trained, because we have the concept of everything that needs to be known regarding orthognathic surgery, right from diagnosis, planning, to mock surgery, to real-time surgery and the post-operative follow-up, and also understanding orthodontics. So there cannot be anybody better than us. So it is a must that for every single surgeon at a mid-level should achieve this. Next will be, depending on your area of interest, if you are a pathology oriented surgeon, head and neck pathology along with oral cancer, which becomes like a super specialty. My only piece of advice for anybody who wants to do oral oncology will be, don't do dental practice, get into oral oncology, stay with that, stay connected with the medical hospital, and spend the rest of your life with that. Never come into the general dental practice, or never dilute yourself with other oral surgical work. Then you will not do justice for that field and for yourself. You will end up getting frustrated. So that will be my advice for head and neck oncology. But if you're doing head and neck pathology like jaw tumors and benign and malignant, then it's okay. You can overlap. You have a lot of reconstructive options to fine tune yourself to. That is one. Second is cleft lip and palate. Yes, it's a wonderful field where the basics of cleft lip and palate can be handled very well right from the infant stage. But more and more will be the secondary deformities at the later stage, which needs to be handled. So again, I would say this is a longer follow-up type of field. You cannot just like that wet yourself with cleft lip and palate and then come back to regular dentistry or regular oral surgery. You will again be handicapped or frustrated with your effort and time you have spent in a younger age spending time with cleft lip and palate. If you are planning to do that, try to get some foundation money or stick on to some place where you will have the complete follow-up up to 18 to 22 years, where you can end up doing distraction or orthognathic surgery in these cleft individuals. That will be the level 3. And of course, the third one is the craniofacial deformity, which can start from any post-traumatic residual deformity, your facial clefts, and it can have any syndromes. That is another ball game. So this is how you can categorize yourself. So before thinking ahead, I will now get into the factors that can be thought about. So fundamentally, it boils down to your interest. We can talk Humpty theory, Humpty things, but whether you are interested in any of this, what I have told is very important. Second, the level of commitment you're going to show to achieve that. Everyone is interested, but are we ready to commit? Are we ready to sacrifice our younger life for that? And to be in any field or any particular subspecialty of oral surgery, you need to spend 3 to 5 years doing it predominantly for you to master it. That will be my suggestion and advice. Of course, you have to take care of the economic status of yourself and your family. If that is a problem, I know a lot of young surgeons who have difficulty, right from education loan to having loans in their house and other commitments. Because of that, they are not able to leave the house or the primary site and go for further training, though they would wish to, or though they would love to, or though they have an opportunity. So these are all the factors that are going to get into your life. And last but not the least, opportunity. Everything is there, sir. I have money, I have place, I can go, my parents will take care of my everything. But do you have the opportunity? Do you get the door knocking for you? That's $1 million question. It depends on your contacts, your networking, your guides and mentors who are going to take care of that part. Okay, now you have decided, yes, let me get trained. What are the options available? Fellowships. Our AOMSI has been wonderful in the past 5 to 6 years or more than that in giving fellowships in trauma, orthognathic oncology, and I think of late aesthetic surgery, if I'm right. We can try to get into that, or similar programs that is being uh, uh, done throughout our country and even abroad. I'm not talking anything about career options abroad. That is beyond the scope of today's presentation. I'm only trying to tell what are the options left to you at the time of you finishing the MDS degree. So fellowship is a must. You can get trained yourself in trauma for a couple of years, then go to orthognathic and then settle in life, or go more into pathology, understand more of the neck vessels, handling major bleeding surgeries, and then come back to your regular oral surgical practice. That will be wonderful. Or because of some financial constraints, you want some salary, then you'll have to get into a college life. Again, depends on whether that particular college what you have chosen has the field of specialty you are wanting to get trained into. You might get into a good college where they are not doing many different procedures, then that will be like you are only working for salary. So the call has to be taken. So many factors come into play. Only the individuals can understand the need, why they are sticking on to one particular city or place or a college. And then the centers. There are private senior surgeons who run centers. You can identify them, you can network, you can get your guidance from mentors or your professors and get into such surgeons, convince them, be available, be committed, then you'll get trained properly in that. So this is how I look at how you have to train. One thing is sure at the end of this slide, training is a must. If you want to be a surgeon at the end of the day, you need to go for further training other than your MDS. Otherwise, you are not going to compete with your colleagues. Okay, sir, I have decided getting into academics like all of you. I want to become an assistant professor and the professor present papers, want to organize conferences, do some research. Yes, well and good. Decide which place you're going to join. You might join in a place where there is active patient flow. That is very important for your further surgical skills. And a center where at least 2 or 3 specialized subspecialty works are regularly going on. Only then it will make a difference for you. Then decide whether you want to be a full-time faculty or a researcher, and please place your cards according to that. That is very important at this young age. Don't take temporary decisions. Think a little bit, even if we have to sacrifice a little bit in the beginning. Okay, now you want to know what most of us do. Most of us are into academics as well as into practice. What we preach in the morning, we don't practice in the evening. We preach oral oral surgery in the morning, practice dentistry in the evening. That is the biggest problem of this generation, our generation of surgeons, where we have found it difficult. We are talking about oral surgery, journal clubs, exams, examiner, board, NAC, JCIA, and then come to dental practice. That is a very difficult decision to make. It is good, but it is up to you. You don't get frustrated after 20 years telling, am I a surgeon? Am I a dentist? We don't know. Make that decision also, again, depending upon your economical background, your comfort level. Then decide whether you want to have a dental practice along with OMF practice, or only OMF practice, or both. The choice is so much is there to confuse you. That is why all this difficulty, but only time can answer. Okay, now you have been exposed to all these things, the 3 levels. You have different ways of getting trained. There are 2 important things you need to understand from this slide. One is being credentialed. Getting an MDS degree is like being credentialed. You are credentialed to handle oral surgical work. Okay, if you join a center, does that give you the privilege to handle all types of cases? No, the center head is going to recommend you based on your credentials, your logbook, your work done all these years, and understand your competency. And then the hospital is going to give you that privilege certificate to tell you, okay, doctor, you can handle oral cancer, you can handle this, you can handle that. That is going to be the order of the day in future in all corporate setups, or in big time hospitals, or in hospitals which have a international tie-up. So please understand, just by getting a degree, you are not worthy enough to operate in any other hospital. You need to show your credentials and get the privilege certificate. This is going to be your future. Okay, before I close, I want to reinstate a fact what my professor, Dr. B. Srinivasan, who is no more now, who used to often tell, before operating, a surgeon should know what not to do than knowing what to do. So it's the right time. You should know when not to put your blade and stop. So that is going to be the key to prevent untoward actions or the complications. Okay, what is there in the other side of the coin? Too much of info available for all our postgraduates. I am sure all my colleagues will agree. When we did PG some 25 years back, nothing was available. We used to find it so difficult to even get an article now. Now the problem is everything is available in our palm top or in our laptop. That is the problem for this generation, because they always think that everything is there. Whenever necessary, they can open up and read or get into it. That's not how it works. Unless you read it or unless you get it done at the right time, it's not going to happen. And individual students or candidates have their own approach, so it's not a one size fit all type approach. And you have to decide at this age and stage whether quality or quantity, which one you want to approach in life. You want to do number of cases without quality, or you want to do few cases with good quality. Even that you can think, because I have to tell you, at the end of this 25th year, we can say priorities of life keep changing every 5 to 10 years. What I wanted in 1990 end 1998 or 1999 or 2000 changed in 2010, and in 2020 it is altogether. I have quit active academics. I cannot believe myself. It's 4 years since I came out of college. I'm happy now, but I have my own regrets. I still want to teach. That's why I came for this presentation. But my other side of the life, that is the private practice, there are so many patients waiting for us to see outside our college, and we are not available during the daytime to treat them. That's when I decided, now that we have done the hard work, like how we do it in a test match, we have learned, we are credentialed, we are aware, we have network. Now is the time in the mid 40s to come out of the college, and another 20 years be available for all your patients. This was your aim in the beginning. You wanted to treat patients, you wanted to operate, and that's exactly what I'm trying to do now. This is why I said our priorities change. I still have regrets not going as an examiner or sitting on a dais or doing something or being head of the department. But that is how you have to decide life. You have to sacrifice something if you want to achieve something. If you understand this, I think life is going to be easy. Last slide. Hard work, dreams, dedication. There is nothing more than this to achieve success. Thank you, guys. Thank you.
Thank you, Ram. Maybe Ram or Deepti can answer. There's a question from the audience. What are the research opportunities after MDS? Are there institutions in like ICMR where we can work after MDS? Either or any of the panelists can answer this. Do we have any opportunity?
I think Dr. Bhagwan or Dr.
Bhagwan,
Shira.
yeah.
So what's the question?
The question is, Bhagwan, is there any opportunity to work in a research institution after MDS?
See,
Like ICMR.
ICMR as of now directly
Doesn't
they
take.
don't
Yes.
take people, but you can do in certain centers like Narayan Hridayal and all. They take fellows who are interested in research only. It's not of technical skills. They are interested in research. They are giving priority. So these people can go to such centers. Whoever is interested in research.
Yeah. Okay. So there's one question from Tej Kiran
Sir,
Shetty.
can I answer that?
Yeah, go ahead.
Please.
Go ahead.
Sir, can I answer that question?
Yeah, go ahead. Go ahead.
Sir, I'll tell you what happens here. For example, institutes like Sri Chitra, they offer full-time PhD programs, but we'll have to clear the CSR. The NET exam has to be cleared. The entrance has to be cleared. Then you can go in for a full-time PhD over here after your MDS. Yeah. And that is given with a very decent stipend, the normal stipend for a PhD fellow. That is available here.
One clarification. One clarification regarding this PhD is to write a PhD for a new graduate, minimum score of 55 is needed % in their MDS. Our time we didn't have marks card. There was no mark sheet at all. So correct. We are exempted if we want to pursue PhD right now. But the present people who are having a mark sheet, minimum is 55% is the qualifying to appear for the entrance exam. There is a minimum qualification one should have.
Yeah.
Yes.
Okay. Now we go to the last presentation. Dr. Kannan, going to speak on paper presentations.
Yeah. So, is my screen visible?
Yeah.
Yes, sir. So, welcome everyone. So, I'm going to talk about how to prepare a paper for in a conference. And before moving on to the topic, why do we need to present papers in the conferences? So, what is the purpose? As the postgraduates, we understand that usually what we do is the postgraduates do for pressure from maybe from the teaching side, and that you have to present papers, and when you go on to go to the conferences, you need to present papers and posters. But the basic idea behind a paper presentation is to expose your work, the kind of work that you're doing, particularly if it is a study, the research work, the thesis which you are doing, you can present it in front of the audience so that you can get a lot of inputs and suggestions and ideas from the audience to whom you are presenting, so that you can improvise on your work future. Also, you can, even if it is not a research work, you can get your doubts clarified. You can improvise on what you are doing by getting more and more inputs from the more experienced chairpersons, the moderators, and the audience sections. And as a postgraduate, what are the challenges that we will be facing? So, as a postgraduate, as a student, we'll be very anxious to present in front of more experienced people in front of you as the audience. And the other important factor is the time limit that you are given. So usually you're given around 8 minutes per paper, and postgraduate will usually find it very difficult to put all the details that he has in those 8 minutes. So that comes with selecting the appropriate contents. So what are the contents that is necessary? The minimum details that is sufficient for the audience to understand the message that you are trying to convey. So selecting the appropriate contents, you don't have to put in all the details that you have, the minimum details that is required so that the audience can understand easily. Again, that is making it more precise. Precise doesn't mean that you don't have to put in all the details, the important details, only with the important and shorter details, making it more crispier and understandable. So to start with, when you want to present a paper, identify the message, what you want to give to the audience, identify the message and identify what you have from this work that you have, what are you trying to convey to the audience. Identify the message and make sure the content that you have is sufficient and evidence-based, and you have the proof for that, and it can be delivered in a given time by the organizers. And once you have decided with what you're going to talk about, then start drafting the contents. Sit and write what are the contents that you're going to include, what are the, like the pictures, what are the statistics, what are you going to include in your paper. So once you've drafted the contents, based on the content, based on the draft, you start collecting the details towards that paper presentation. So like the pictures, the statistics, the articles that you want to take as a reference, which supports your article or which is against your article. So try to select all those, collect all those details like the pictures and the statistics. So usual the regulations. I'll move on. My presentation will be mostly how to prepare, like not the scientific data. I'm asked to talk about what is the method of preparing, like the slide formatting, etc. So usually the regulations will be around minutes per paper. So you have to stick to the timing 8 minutes with 2 minutes of for question allotted for the questions from the chairperson or the audiences. And ideally speaking, if you want to put in more theory, it is 1 minute per slide will be very ideal. Is 8 or 9 slides will be sufficient. Apart from the title slide and the acknowledgements, those are extras. And if you are in pictures and giving in more graphical representations, maybe you can extend your presentations to maximum of 15 to 16. Paper presentations have a minimalistic approach. So with the minimum text and minimum lines, minimum images, minimum information. So minimalistic approach doesn't mean that you cut short on your work and then give it as a presentation. It is taking the minimum number of details that is required for you to pass on the message from yourself to the audiences. So the minimalistic approach doesn't mean that you're cut shorting. You're taking the minimum number of details from presenting it in front of the minimum lines. Try to have as minimum lines as possible. And see the slide quoted as an example. There are too many details in it. So when you look into such slides, you get bored and you lose interest. You don't tend to read. So the messages that you're going to convey to them. Maximum 9 slides, or you can take it up to 15 to 16. This title and can be excluded. You can have a slide for the title, and the title should be very excellent.
I think we lost him. So, Jimson, do you have his presentation?
Yeah, I think he's rejoining. I will share screen.
One thing very important in presentations is that you should follow the KISS format, that keep it short and simple, keep it simplistic, as he was saying, and not too many colors, and you know,
Kannan?
okay, I think it was.
Kannan,
Shana, you can continue that presentation. You can just read that information.
Yeah, but please don't ask me questions on this, huh? So, like what we regularly have in our postgraduate orientation program, we have one person come over and then he has a 1 hour session on how to make a effective PowerPoint presentation. So basically, you should not have confusing fonts, something that looks very exotic to you but may not look good on the screen. Okay, you should keep it extremely, something like Google, if you have it, that's very good, minimalistic. Now what happened? Yeah.
Can I use?
Yeah,
Can
Kannan.
I use?
Kannan. Kannan, I was trying to steal your show.
Yeah, Kannan is back.
Yeah.
Yes, sir. When the contents, so now Jim, can you share the slides? I'll just go ahead. When you're talking about the content, first, the title should be a self-explanatory one, and if someone reads into the title, they should realize what is the content that you're trying to deliver. Only then they will start developing interest on your paper. And the next slide should be some slides before, sir. I think a couple of slides before, I think. No, sir. 4 slides before. 2 more, sir. Yes, sir, this one. And the next slide should be one slide next. One slide for an introduction. You can have one slide for the next slide. Sir. One slide for the introduction. So introduction, no, the previous one, sir. Your introduction should basically have what is content of your study and the relevant background information about your study and what you are trying to present to the audience. You can have for the introduction, and the next one should be your objective. If your objective is very brief enough, you can include the objective in your introduction, and your objective should be relevant to the point what you're trying to discuss in your discussion part. And if you are discussing something about the methods, you can have 1 or 2 slides for explaining those methods. And coming to the results, you don't have to put in all the results. Suppose, for example, you may be having all the audience doesn't need all the demographic data. A simple and a very simple table or more of a graphical representation. Graphical representations can be of more helpful and more relevant than having an elaborate result in your presentation. The next slide. And then followed by the discussion. Again, you can have 2 or 3 slides for your discussion, and your discussion you should discuss and correlate the results that you have obtained. What are the results that you have obtained, whether it's positive or negative? What are the results that you have obtained? And your presentation should also should discuss about the strengths and the limitations. So if you discuss about the limitations, you may get some inputs from the audience side which can strengthen your study. And then comes 2 or 3 slides for the references that support your presentation. So the other references from a standard articles, standard journals as a reference, and you can quote them and you can support your study. Something which says against your study, but you have got the other way around. You can have 2 or 3 references and a conclusion. So what you are trying to present to the audience. So your conclusion should have a very clear take-home message. So what you are trying to say, what you're trying to present in with your paper, there should be a clear take-home message. You can have 1 slide for the conclusions, and then finally the acknowledgements. So this amounts to totally around 8 to 9 slides, and maximum you can go on to 14 to 15 slides if you want to do it in that given 8 minutes of time. And coming to the slide formatting, so it should be a contrasting, either a dark background with light colored text or a light background with a dark colored text. It's better when you have a lighter background with a dark colored text, like a whiter or a much lighter background with a black or blue colored text. Maybe a red color one, which gives you much more easier to identify those areas. And the fonts should not be too small or should not be too large, and it should be easily readable. There should not be any styling in your fonts in your presentation. So for example, like the Arials, the Times Romans, the Calibri bodies, something like that. A readable font, no styles involved, and it should be of a standard size and equal size. And when you want to emphasize on a particular, it is always better to bolden that particular point rather than underlining. So underlining maybe sometimes lead to confusion. So boldening makes it easier for the reader to look into those points. and don't ever try to adopt an all caps attitude. So if you put all the letters in the capitals, again, that may not be easy reader to go through it. Spacing, there should be a minimum of limit. Give adequate spacing, minimum of one lines and between words, spacing between the words, so that it makes it easier to read through the lines. Adequate margins on all the four sides, right, left, top, and the bottom. Don't take it to the end of your slide. Sometimes the projector may not project the entire slide. So give adequate margins. And the content should be precise and explanative, and don't add more than 5 to 6 words in a line and not more than 5 to 6 sentences per slide. Next one. Next. Okay. What are the things you have to avoid? Avoid longer sentences or full sentences. Again, people may not read through the entire sentence, not be look good, small and crispy. And don't try to put in more details in a single slide. Multiple simple slides is always worse, and when compared to a single, always better than a single complicated slide. When you try to put in more details in a single complicated slide, people may not be able to follow it. Rather than, you can split those slides into multiple slides and make it more simpler, so that you can deliver the message that you want to convey to the people. Okay, then don't too many words or sentences in your slide maybe the people start losing interest and may be more confusing, and having more animations and more of unwanted graphics and overdoing your slides that tend to distract the audience. So try to put in only what you want to convey, and try to have more pictures than words. And when, as I said earlier, in the results column, try to have more smaller tables and graphical representations, not like one what you have in this picture. The next one. So coming to the end of it, what are the tips? Try to have one more copy of the presentation. Usually you carry it in your pen drive. Try to copy it in another pen drive, have it as a backup, and also email your presentation to yourself, to your mail ID, and also to a friend who will be present during your presentation. It is always better to have good backups. And if you are trying to present it with your own laptop, always carry a converter, so that you don't lose your time or get panicked or anxious. And practicing and rehearsing, keep practicing. So practicing and rehearsing is going to help you in fine tuning yourself. So what are the contents, and what are the content? You won't miss out on anything, and you keep remembering the slides. So what will be the next slide, and there will be a good flow when you practice and rehearsing, and it also helps you to have a good timing. You don't have to overdo your stipulated timing. And at the end of it, try to expect some questions with the help of your friends and staffs. Expect what are the questions relevant to your discussion, relevant to your presentation, and try to get answers for those questions and be ready, be mentally prepared. That helps you to be prepared mentally. And when you are delivering, so next slide, when you're delivering your lecture, always don't look to the screen or your laptop. It doesn't look good. So you can have a momentary look into your screen, but it's always better to have an eye contact with the audience, and make sure that there is a sync between what you are discussing and what is projected on the screen. Don't discuss about something which is not in the screen, maybe jumping the slides. Don't do that. So make sure there is a good sync between what you're saying and what is being projected. And when you want to particularly tell something, use a pointer, so that when you want the audience to look into a particular area, use a pointer. The use of the pointer also makes the audience to get attentive to that particular area. So direct the attention of the audience, and try to finish it before your time limit. Maybe 8 minutes means spot on at 8 minutes. So that also helps to shows that you are respecting the speaker who is coming next. So that is the end of my presentation. So I'd like to thank Dr. Jimson, Dr. Elevenil for giving me this opportunity to talk in front of you. So thank you very much, and thank you.
Thank you, Kannan. The case discussion slides were also made by you. Very simple background,
Yes, sir.
and just the bare minimum detail that was needed. Excellent presentation. And
Yes, sir.
there are
Thank you,
many
sir.
questions that came up. All of them may have got answered, I think, by the erudite panel, which is here, Dr. Bhagwan Das, Dr. Manjunath, Dr. Ramkumar, Dr. Kannan, and Dr. Deepti. I think this wraps up the session. Thank you, Dr. Reena, Dr. Jimson, TN, and Puducherry branch of AOMSI for this wonderful opportunity that was given to us. I hope the panel has answered the question, make things very lucid for everyone, and the audience was pretty receptive. I could see a lot of in the chat boxes about how good the presentations were. So thank you, panelists, for the time you spared for this particular event. Thank you so much.
Thank you, Dr. Shanai.
Thank you. Thank you,
And,
sir. Thank you, sir.
Yeah. Thank you, Striker, for
Striker.
really, doing a good job of spreading
thank
this
you.
knowledge.
Thank you, especially Dr. Jimson and the entire TN Pondi branch and all the panelists.
Yes, same here. Thank you all, Jim, 11L and team.
11L.
Yeah,
I remember Ram, so sorry to interrupt. So sorry to interrupt. It's just that, the dry run that we had for this particular presentation itself was about 2 hours. So you can imagine how much effort they're putting in week after week.
Yeah, special thanks to Deepti and Kannan for preparing elaborate cases.
Yeah.
And
you,
to the
Deepti.
stalwarts, Manju and Bhagwan, for having spent their quality time with us. Thank you, buddy.
sir.
Thank you all.
Thank you, Bhagwan sir. Thank you, Ram sir.
Thank you, everyone.
Shenoy sir. Manju sir. Thank you so much, Kannan.
Manju,
Thank
we
you
are
so much.
waiting. We are waiting
Yes, sir.
Yeah.
for the national conference.
Jimson, amazing job, man. TN, I swear, you all, Tamil Nadu, Jimson and team, I might have missed 11L and others.
Yeah.
You people are doing an amazing job. Soft to you, I swear. Really, really commendable.
Sir, thank you once again.
Thanks a lot.
Yeah.
My last trip before the lockdown happened was to Madurai.
Yeah, no wonder.
11 months back, yeah.
No wonder you shut down us.
Yes, sir.
Oh.
And Ram, excellent. After, when I was keenly listening to your what after MDs, even I wanted to know what exactly now.
Was there any sense made?
Definitely.
Of course.
Yeah, a lot of things change, no? Every 5 years, 10 years, our priorities change.
True.
What we wanted to become is not what we really do.
Yes.
And what we preach in the morning is not what we do in the evening.
Totally agree with you.
Yep. Okay, let us have a debate like that in Mangalore if time permits.
Sure.
What after life after 5 years, 10 years? That will be interesting.
The Crown Prince of TMJ was also there in the audience, Dr. Abhay Kamath. Yeah. So he's given very valuable tips.
Oh, very good.
Yeah.
And somebody was asking a lot of questions. Dr. Tej Kiran is my PG. I'll answer whatever is this.
He wanted to know whether he can do MBBS after MDS.
Yeah,
You ask him to prepare for NEET.
Okay, thank
Very
you,
good,
guys.
Thanks,
Thank
Dr. Shanai.
Thank you also. Thank you. Thank you very much.
Thank you. Bye.
Please don't log off. Yeah. Yeah, that is how simple.
Thank you, sir.
Managing complications can be, and you all heard it from the masters, and to avoid complications as well. Thank you, Dr. Ramakrishna Shanai, for the superb moderation of the session.
Yeah.
Thank you so
Special
much.
thanks to Shanai.
And,
Did a fabulous job. You are a cool like cucumber.
And it's a pleasure on behalf
If
of
I was you in your position, I would have been like, oh, it's getting late. But you took it like in style. Slowly.
I'm cool like a melon. Not a
I
cucumber.
see. Okay.
and,
Thank you, Shanai, sir. I'm
Thanks,
very
sir.
happy to have been part of your panel, sir. Thank you, sir.
Thank you so much.
and it's been my pleasure on behalf of the president and the EC to thank all the panelists. And I know that you have all been busy in your work, but still have given your time and honored our invitation.
Still, our lunch coupon has not received home. We are waiting.
To the success of the
Sunday biryani coupon. I thought you will get.
Thank you. Thank you, Dr. Senthil, Dr. Suresh, and Dr. Ilavenil for your help and support. Thank you, Team Striker, Mayank and Chandru, and the Craniofacial Academy of Striker for your continued support. and all the participants who week after week join the learning session. Thank you all. Thank you. Thank all the heads of the department from all over India for encouraging their trainees to participate. And I thank the AMSA President, Dr. Veerababu, the Honorary General Secretary, Dr. Preetham, for their support, the Executive Committee, and members of the State Branch as well. And thank you all for the appreciation for the work that we have been doing for the last few months. Yes, it is a fantastic teamwork. It is not an individual who's doing it. It's a team that is behind this work, and all the credit goes to the team behind this program. And it is not about the number of programs that we have conducted. It is a knowledge that is being shared by all the speakers who have agreed and participated in our programs, from young surgeons to the doyens, from the state, from the national and international speakers as well. So thank you all for your contribution, and see you all next week at the same time for more learning. And that is going to be a multidisciplinary panel with ENT surgeon and neurosurgeon and ophthalmologist, oculoplastic surgeon and an anesthesiologist who's joining for the next week's program. So thank you all once again, and see you next week.
Thank you, man.
Stay
Thank you,
safe.
Jimson. Thank you once again.
Yeah.
Thank you. Thank you.